الله الرحمن الرحيم. أستاذ دكتور حازم عبد العظيم, the chairperson of this webinar. Please give us an introduction لسعادة البيه.
اوكي، بسم الله الرحمن الرحيم. ابدا كلمتي بشكرك يا دكتور حسام على الانيشيتيف دي وعلى المجهود اللي عملته تو كولكت الجروب اللي هم انترستد والناس اللي هي مرت باكسبيرينس خاص في هذا الموضوع. بعد ما بشكرك بشكر المجموعه اللي موجوده على تفضلهم بتفريغ وقتهم والدخول معانا في هذا الموضوع. الظروف اللي موجوده دلوقتي ظروف يعني غريبه شويه، زي ما انا كنت بقول دلوقتي، شيء غير مسبوق ولم يمر به العالم قبل كده من زمن طويل جدا. كان حصل قبل كده الشيء اللي قريب شويه من دي، الانفلونزا الاسبانيه او الاسيويه، اللي اجتاحت برضو مجموعه من البلاد، وقيل انها اجتاحت العالم كله برضو، ولكن ده مش ثابت ابدا، لانه في بعض البلاد لم يذكر عنها شيء في هذا الموضوع، ودرجه الاجتياح كانت مختلفه. برضو في الوقت بتاع الاسيويه ده ما كانش لسه في الحركه العنيفه والكبيره والواسعه بتاعه البشر خلال العالم. السفر ساعتها كان بالمراكب والكلام ده، وده كان طبعا شيء يعتبر في منتهى البطء بالنسبه للي موجود دلوقتي. ويقال ان في هذا الوقت وقفوا بعض القطارات. يعني كانت طبعا القطر زي ما احنا كنا عارفين صورته القديمه كان بيبقى عامل زي العماره المتحركه يعني، والسفن نفس الكلام. انما اللي احنا موجودين فيه دلوقتي دوت، زي ما انا كنت لسه بقول لحضراتكم دلوقتي، شيء جعل حديث الساعه بين اي مجموعه من البشر بتتكلم مع بعض، بتتكلم في هذا الموضوع وفيما حدث فيه وفي الاحداث بتاعته. الشيء الغريب برضو في هذا الموضوع انه بنسمع كلام كله كلام متنقل ومتواتر، واساسه من الصحه العلميه ما هوش قوي قوي لدرجه تقنع ناس زيكم من علماء الطب. اللي قصدنا اننا نعمله فعلا اننا نعرف من بعض خبره بعض، ويعني اراء بعض في بعض الامور، وربما ده يكون شيء جميل انه يفيدنا في ازاي نقدر بعد كده نعيش ونتصرف في الشويه اللي جايين دول بناء على الاكسبيرينس بتاع حضراتكم. الدكتور حسام اختار مجموعه من الاساتذه الافاضل والزملاء اللي بيشتغلوا في انجلترا بالذات، ويمكن اختيار انجلترا اختيار كويس وحكيم. انجلترا بلد انا اشتغلت فيها وتعلمت فيها واتصلت بيها بطرق متعدده. السيستم بتاعنا الاساسي في الدراسه كان سيستم انجليزي، ودراسه الطب في مصر متعلقه الى حد كبير جدا بشغل جراحه العظام والطب في مصر، ويتعلق جدا بدراسه الكتب. كان كل الكتب اللي كنا بنذاكرها زمان كانت كلها كتب اصولها انجليزيه. يمكن يكون في الاكسبيرينس الانجليزي سم هوموجينيستي مع اللي احنا نحتاجه في مصر. المقدمه دي كافيه جدا، وكنت بعتبرها طويله شويه لاني مشتاق ان انا اشوفكم كلكم بعد المده الطويله دي. البانل كلها من زملائي حاليا وتلامذتي وابنائي وابناء اصدقائي فيما سبق. بدي الكلمه للدكتور حسام تو انتروديوس الفاكولتي والبانل والباترن اللي هنمشي عليه، وان شاء الله نستمتع كلنا بهذه الميتنج. اتفضل دكتور.
شكرا جزيلا استاذنا الدكتور حازم بيه عبد العظيم. بسم الله الرحمن الرحيم. I'm very happy to be here and to be organizing and moderating this webinar. بروفيسور حازم عبد العظيم ادانا الشرف انه يبقى معانا النهارده. كلنا نعرف دكتور حازم. دكتور حازم is a national and an international figure, the past head of orthopedic department Cairo University, past vice dean of the Faculty of Medicine Cairo University, Egyptian Orthopedic Association president, founder of the Pelvic and Hip Society, and founder of the Osteoporosis Society. يعني حاجات كتير قوي قوي. past chair of the AO Trauma Middle East and North Africa, a very high level leader in AO Trauma worldwide. بشكرك تاني يا دكتور حازم، وكتر الف خيرك بوجودك معانا. is a big addition to us. The four يعني strikers of this this webinar are our colleagues from the UK. First, Mr. Fadi Sedra, who is a consultant orthopedic and spinal surgeon at the Royal London Hospital. Thank you, Fadi, for joining us and actually doing a lot of work to make this happen and possible. Mr. Amgad Nakhla is a consultant orthopedic surgeon at the James Paget University Hospital. Thank you, Amgad, for joining us. طبعا Mr. Ismail Fathallah is a consultant lower limb surgeon in Worcestershire Acute Hospitals NHS Trust West Midlands. Thank you, Ismail. And finally, Mr. Sharif Haqqi, consultant bariatric and gastrointestinal surgeon at the Imperial College Healthcare NHS Trust. ثانك يو شريف كان حاسس انه يبقى يعني موحود وسط جراحين العظام العمالقه ابو عضلات وكده، بس انا طمنته ان احنا كلنا بنحبه وكلنا اوبيز وهنحتاج لخدماته one way or the other يعني. Then our very distinguished panelists that will ask the questions and share in the discussion and guide us through this with our chairman, Professor Hazem. Of course, Professor Ali Abamadawi is the professor and head of department of neurosurgery in the Swiss Canal University. Professor Ali Abamadawi is also the founder of the Egyptian Spine Association with other colleagues, also a founder of the Egyptian Spine Journal, which is probably the best in the region as a journal. He's also the current head of chair of the Egyptian Council of the AO Spine. Thank you, Dr. Ali, for joining us. Again, Professor and my dear brother and friend, Wael Obtan. Professor Wael Obtan is the professor of orthopedic and spinal surgery, one of the in Cairo University, and one of the leaders of spine deformity surgery in the country. Started doing deformity in the modern way over 20 years. كمان Dr. Wael is the current Egyptian Spine Association president and also served in the council of the AO Spine Egypt. Thank you, Wael, for accepting to join us. Finally, our colleague Mohammed Al-Mishtawi, who is struggling somehow to get with us. I'm sure he will. Professor Mohammed Al-Mishtawi is a very super huge surgeon, a spine surgeon. He is a professor of orthopedic and spinal surgery in the University of Asyut, and he is one also of the leaders of spine deformity surgery in the country. Okay, so this is the introduction of our faculty and panelists. Let me just go to business. The whole idea of this webinar that these distinguished strikers from the UK will be asked 8 questions. Each question will be asked from one of our moderators and one of our panelists, and he will answer the question. And during his answer to the question, he will ask a question to the attendees, which will require a vote. So you'll be asked to vote, and then he will comment on the vote and continue with his answer. Once the answer of the question is done, the panelists with Professor Hazem Abdelazim, our chairman, will start sort of discussing his answer and asking questions on all that. And during this, the questions from the attendees will be read by one of us, and also, if possible, one of the attendees who raises his hand to ask a question will give him the chance to do that. I'm very sorry, we will have to cut a lot of the questions. We will try to look at the common things or the most commonly asked questions, but again, because of the time restriction, otherwise we will probably spend the whole night doing this. Professor Mishtawi is with us. Dr. Mishtawi, Assalamu alaikum. Please unmute yourself. I already introduced you, but I will introduce you again. Professor Mohammed Al-Mishtawi is professor of orthopedic and spinal surgery, Asyut University, one of the leaders of spine deformity surgery in the country. Also, Mohammed Al-Mishtawi is a founder of the Egyptian Spine Association and also a past council member of the AO Spine Egypt Council. So, we're about to start. We can start. Our first question, Professor Wael Obtan will ask the question.
Shukran, Dr. Hussam. First of all, I would like to thank you for your great effort in organizing such an event and for inviting me as a panelist here. طبعا يسعدني ويشرفني وجود our dear professor Dr. Hazem Abdelazim as our chair. Dr. Hazem was my supervisor in both my master's degree and my MD thesis, and he's been a godfather not only to me but to generations and generations of orthopedic surgeons. It's a great pleasure to have you with us, sir, tonight. We'll start with the format الحقيقة الدكتور حسام اقترحها. We'll start questions first. My question will be to our dear friend and co-orthopedic surgeon, Dr. Sharif Haqqi. Sharif, you work in one of the busiest hospitals in London. Can you please shed some light on the process in accident and emergency department? For example, do patients with respiratory symptoms have a separate entrance? How do they get segregated from other patients, etc.? Would you please share your experience with us?
Thank you very much, Professor Upton, for introducing me. Thank you very much, Professor Hazem Abdulazim, and Dr. Hussam. I really appreciate the effort that you put behind the scenes to bring this thing to light. I also have to thank Fadi for organizing a few things to make this happen, and it's very good to see my colleagues Amgad and Ismail and to be hosted by the panelists. It's great to be here. There's طبعا في pressure عليا ان انا الوحيد اللي مش دكتور عظم في المجموعه، فانا بحاول اقول ان انا عظم انتساب، ان انا كنت امتيازي في اسم جراحه العظم في يوم من الايام فانا الحقيقه انا جراح، انا general surgeon، بس انا at the time at the height of the COVID pandemic when it first started picking up and the cases picked up in London, it happened to be that I was on call for about 13 days straight. I shared those experiences with my good friend Ismail on a daily basis through WhatsApp. I did develop a good experience to start with. We weren't very protected early on, and then we started establishing things a bit late, I have to say, in the UK, and I believe that this is one of the reasons that we have large numbers and we have unfortunately good exposure to COVID, and we all have experiences to share, myself and the three of my colleagues who are going to speak. I'm going to share a few slides with you. So let me just start by saying that can you see me and can you hear me and can you see my screen?
Oh, yes.
Yes, okay, thank you. So St. Mary's Hospital is one of the busiest hospitals in London. It is a small hospital, nothing compared to where we all trained, myself and my colleagues, in Qasr Al Aini. So it is probably easier to manage things and outflow and income of patients than a large university hospital with a big entrance or a big emergency department. Having said that, we have followed what was national guidance that's applied in my hospital, in Amgad's, in Fadi's, and Ismail's. It is not, you don't pick and choose, you can modify things according to your structure. The national guidance came out in pieces. They first came up with clinical management guidance, and then safety guidance, and then hospital guidance, and we were always guided by Public Healthcare England, اللي هي زي ما تكون هيئة محاول ليها يعني إن هي تطمن إن المستشفيات والأطباء بأمن وسلام طبعا، وأهمهم العيانين. فدي procedures اللي احنا that are followed. We don't have to go through them. I'm just going to explain them very briefly. وهو المريض اللي داخل على المستشفى هو في الأول بيقابل عن طريق health care practitioner, nurse أو doctor in full PPE واقف بره باب الطوارئ أو أبواب الطوارئ depending على المستشفى organized إزاي. وبيقابل العيان regardless بقى العيان ده داخل بكسر ولا داخل ب acute appendicitis ولا جاي عشان symptoms of COVID. هو بيقابله بره المستشفى. احنا المستشفى بتاعتنا عملنا حاجه زي بالونه كده صغيره بره المستشفى. كان بيسال الاسئله دي كانت سكريننج تيستس يشوف العيان عنده upper airway symptoms، عنده حراره، عنده loss of smell. وفي الاول loss of smell دي ما كانتش موجوده لحد اما في الاخر we established a structured proforma بتاعت 5 اسئله وبنقيس حراره ويتقاس حراره المريض. الاسئله دي كانت على الحراره، على الكحه، على
I'm very sorry, but your screen doesn't show. It shows only the folder. It doesn't show it's open. It shows us like surgery at time of pandemic, like the name of the folder. It's a black screen with a horizontal line كده مكتوب عليه surgery at the time of the pandemic. Is this what you mean? Well,
no.
it's
لا I'm on my PowerPoint slides already.
لا ما احنا we can't see that.
Okay, I'm gonna try again.
Oh.
Okay, and I hope that this time it works.
You did share it successfully قبل كده. Yes.
Can you see me?
Yes, we can see this now.
I'm very sorry. Thank you very much for prompting me to do this.
Can you just put it on full screen, please?
Of course. For some reason,
you just need to go down to the right, down to the, yes.
Okay.
That's perfect.
Thank you very much for prompting me to do this. So basically what I was at the stage of saying that my hospital, St. Mary's Hospital, is a small hospital compared to the large hospital of Al-Qasr Al-Aini or other university teaching hospitals in Egypt, because it's a small bed capacity hospital with just 2 entrances to the accident and emergency department, so it's easy to contain. But anyway, I was just saying that we follow national guidance. There are about 6 more of those. They are public, as Ismail was saying earlier, they're published by the National Health Service of England. Scotland has a separate one, which is not that much different, and also in association with Public Healthcare England. Now, initially, when a patient presents to the hospital, they generally present to accident and emergency. As you can see, the accident and emergency departments are blocked. You cannot walk into the accident and emergency department as you would do. You are met outside by this lovely lady like this, who is a healthcare worker in full PPE, to ask you a set of questions to screen for COVID symptoms. Now, this does not have to mean that you're presenting with COVID. Anyone who's presenting to the hospital, regardless of presentation, is asked these set of questions. And accordingly, according to just this input by this one person, the patient is either classified as green, red, or amber. Now, let me explain that this scenario is not suitable for most of the cases, for all cases, I mean. So a patient who is arriving through a road traffic accident, who is brought in by ambulance, who is going to arrive to accident emergency resus, is by definition, unfortunately, COVID red. It is an amber zone, but it is not really amber, because the resus is a mix of everyone who's coming with a high velocity injury, and in trauma centers like mine, it was quite busy and it was really a strict, COVID was everywhere. Now, unfortunately, very early on in the pandemic, we approached patients like this, not in full PPE. And I had a particular situation, unfortunately, where I had a patient who was run over by a car twice, who arrived to the hospital needing an immediate laparotomy and an emergency department thoracotomy. And let me tell you that this was only the 2nd time in my life that I have done a thoracotomy in the emergency department. And I have done all this with just a normal surgical mask, gloves, and I actually was in my normal scrubs. And this patient was post-operative in the ITU, screened to be COVID positive, but he died 2 days later. So it was very difficult to determine. So basically, patients who are arriving to accident and emergency resus should be met by doctors who are ready in full PPE. So there should always be someone ready in full PPE to manage accordingly. Amber zones are zones which are indeterminate. You are not sure about this patient's particular COVID status, or there are areas in the hospital, by the way, this just does not apply to A&E, it applies to everywhere else in the hospital. I'm sure my colleagues are going to explain that too, but there are areas in the hospital which are COVID wards, areas which are COVID indeterminate, which are amber, and then the green zones where you are safe. But also, safe in this particular time of this pandemic is not too safe. You cannot be too safe and you cannot be too casual about the way that you see your patients and the way that you do things. You can't do things the way that we did in December 2019. You have to be cautious, and there is, we will be discussing personal protective equipment, and so will my colleagues, but you have to approach all patients with caution. So there is a classification of the kind of entries I do apologize. This was the slide for the next question. So there is a red zone for COVID positive, for patients who answer the questionnaire with the likelihood of COVID positivity. Of course, we're not going to wait for the PCR result, and all these patients are going to get a chest X-ray or a CT scan to confirm that. In the COVID red space, there is 1 bed empty. So just in case that this patient is not really COVID red, he has not been infected by someone just straight next to him, there is a good space of 1.8 meters between one patient and the other. COVID ambers are the indeterminate ones. And these are patients or areas in the hospital with the possibility of COVID or the possibility of low viral load. COVID green are the safe areas. So that is my initial introduction about patients in accident and emergency, and how we approach them with a questionnaire and the classification through 3 different zones. Now, patients with the red zone, all the doctors have to be in full PPE. Patients in full PPE will be discussed later, but nothing short of what I have in the slide of a gown, an apron, an FFP3 mask or higher, eye protection, and gloves. In the amber zone, you should also have, by the way, because this has been upgraded, these are trust guidance, not national guidance, but the national guidance, the Public Healthcare England guidance have changed twice, but one in the amber zone to be super safe also has to be in full PPE. And finally, the green is just a normal surgical mask and gloves. And that is my introductory slide. I'll pass on to my colleagues after I ask the attendees a simple question, which will be put to them right now.
Yes, thank you, Sharif. Hadir, are you going to do this or shall I do it? Yes, I already do it. Okay, this is the question that Sharif wants us to answer. Can you read it, Sharif, please?
So this is a patient who has arrived to the hospital following a road traffic accident requiring emergency surgery. He was confirmed to have ground glass changes of his lung basis on the CT scan, and the report suggested the possibility of COVID. The PCR was not done. In terms of protective measures, there are 4 possible answers. All staff in the OR should be donning full PPE. This type of surgery is not aerosol generating, and there is no need for full PPE for the operating staff. There is no need for the patient to wear a mask during transfer if it can be tolerated. This does not minimize infection. And finally, option D is after surgery, the patient can be transferred to the green clean ICU as he still did not have the PCR.
So, I mean, only 6 have voted. I don't know why, but they've all opted for the first option, which is...
the time for the poll ran out before people finished voting, I think.
Okay, right. So that's it. What would your answer be, Sharif?
So الحقيقه ده سؤال سهل وانا حاطه بس quite simply عشان احنا كدكاتره نحمي نفسنا، لان مهم جدا عشان المنظومه الصحيه تمشي وتكمل على خير ان احنا نفسنا ما نتصابش. فالحقيقه اجابه السؤال ده صح 100% زي ما الزملاء حطوه، ان هو we should all be wearing full PPE when it is COVID in this case possible, and it will be COVID positive, and in this particular case that I'm describing, it was COVID positive. We should be in full PPE and nothing short of that, because we otherwise expose ourselves. So, and I would like to say that point number 3 is an important point, is that if there is no maxillofacial injuries or nasopharyngeal injuries and the patient can be wearing a mask himself during the transfer, it is very important that the patient is wearing a mask. So it is a perfectly answered question with 100% record. So thank you very much.
Excellent. Well, would you just start the discussion, Professor Hazem? If you have any questions.
Yes, please. Sharif, thank you very much for this very concise but extremely useful knowledge. Guidelines دلوقتي, do they state how you manage مثلا عيان جاي لك في الاي ار ومحتاج CPR, هل وعنده possible COVID او established COVID, هل في حاجه بنعملها مختلفه عن السي بي ار اللي بنعمله في الريجولار patients؟
الحقيقه الريسستيشن كونسل طلع نيو جايد لاينز. كنت الحقيقه انا اتعلمت الموضوع ده لما اتعلمت رعايه مركزه عشان نساعد في الفتره اللي احنا والحقيقه ما احتاجوناش يعني. بس هو في الاول كانوا قالوا ان هي هتطلع without chest compressions، فكانت هتبقى pointless ان هو البيشنت were COVID positive خلاص just leave them. يعني give them الميديكيشن و just wait adrenaline noradrenaline and so on. بس لا اللي طلعت you do the chest compressions but you do not do mouth to mouth breathing. Mouth to mouth breathing in COVID suspected حتى مش COVID positive, you are not supposed to do that لأن حضرتك if you think about it this is asking for trouble for the doctor. yes وطبعا it depends على who is running the show. بس احنا we've had an intensivist and an anesthetist, always 2 consultants available. They were called the COVID team. They were called the gold member. هم الاثنين are gold member. هم دول دورهم ان هم يقرروا مين اللي هيتعمل له مين اللي هيتعمل له resuscitation to start with ولا we're just going to give up. لان كتير منهم كانوا care home residents with multiple comorbidities and they were very very selective في الاول عشان ال availability والسيرج والسوبر سيرج. احنا ما وصلناش للسوبر سيرج، يعني انا مستشفيتي ابتدت ب 41 سرير رعايه، والسيرج بلان كانت ان احنا نوصل ل 80، والسوبر سيرج كانت نوصل ل 144 سرير في مستشفى سانت ماريز هوسبيتال باخذ العمليات والكلام من ده. احنا وصلنا في مستشفيتي بس ل 88 عيان اللي هو اول مرحله السوبر سيرج. فهم they were selective، وطبعا ده decision كبير قوي علينا، والحمد لله ان احنا جراحين ما ناخدش قرار زي ده، بس they were super selective about who requires resuscitation and who doesn't.
Excellent. Now في سؤال من الدكتور حسام جاد من كفر الشيخ. دكتور حسام ازيك؟ Can you please tell us the basic 5 questions to ask the patient before examining?
Yes. So one of the questions was if you have fever, and then they replaced that with taking the temperature.
Mm-hmm.
Number 2 is whether the patient has bouts of cough. Number 3, or actually it is number 1, whether the patient is a care home resident or arriving from home. Because care home residents do not necessarily mean that they're debilitated. Some people just live in care homes. Number 4 were GI symptoms, okay, because many of the cases present with just diarrhea and GI symptoms. And question number 5 is recent, whether the patient has lost his sense of smell and his sense of taste. Now, again, I would just like to explain to Dr. Sam, my colleague, that these 5 questions are not, these are not Public Healthcare England or NHS England. They are not national. These are my local hospital at St. Mary's and the Imperial Trust policy. And perhaps Fadi, Ismail, and Amgad have different questions on arrival.
Excellent. Thank you very much. We're running out of time here, so we better move to the second question. And Professor Ali Abumadawi should ask it.
Yes, hello, everybody. Thank you, Professor Hassam, for the very nice webinar. Actually, I have a question to Dr. Ismail regarding the outcome. We might came across paper from the Wuhan area, which is the center of the pandemic in China, and they're reporting that the outcome of surgery during this pandemic is worse than outcome during different times. Do you come across some experience like this?
First of all, thank you very much for having me today. وقبل ما ابتدي اقول اي حاجه اللي احب اقوله لكم واللي انا متاكد ان زمايلي برضو هيوافقوا عليه، ان احنا what we are sharing with you now is an experience. اوكي، الاكسبيرينس بتاعتنا دي مبنيه على ظروف بلد وظروف مستشفيات وظروف مؤسسات. فالديسيجن ميكنج بتاعنا احنا we are sharing الاكسبيرينس، واحنا عارفين ان جزء منه ممكن يكون applicable في مصر وجزء منه مش ممكن يكون applicable في مصر. الحاجه الثانيه بخصوص البيبر اللي طالعه من ووهان، وزي ما استاذنا الدكتور حازم عبد العظيم كان قال في الاول، الايفيدنس اللي طالع النهارده we are in the process of building evidence. واي evidence بيطلع مهما كان قوته هو لا يتعدى مجموعه صغيره من العيانين. واللي انا هرد على حضرتك في السؤال بتاع حضرتك واقول لحضرتك ازاي الكلام ده اتغير وايه اللي حصل لنا through a presentation انا كنت حضرتها. فانا I will share السكرين معاكم ثانيه واحده. My presentation will be in English. If there is any problem just let me know please. انا شغال في ووسترشير ودي مقاطعه في الويست ميدلاندز، واللي حصل ان احنا برضه my experience comes from the fact ان احنا trauma and orthopedics، ولو في حد كان شغال throughout البانديميك دي من الاول ما بطلش شغل هو احنا. حصل ان في كذا حد من زمايلي fell off sick، وبالتالي بقينا احنا 3 بس او 4 اللي شايلين الشغل في الديبارتمنت. الامباكت on the surgical activity. The Wuhan study is a single center study with high mortality rate. Okay, when we read it, it induced a lot of panic without giving us enough guidance. Luckily, what happened at the time is that the UK came under lockdown with subsequent reduction in orthopedic emergency admissions. There is no road traffic accidents, there is no polytrauma patients, not as much as we would. At the same time, elective work was completely suspended on the 18th of March, and I can remember exactly what happened on the day. I had an operating theater list with 4 joints to be replaced. Upon completion of the first one, المانجمنت اتكلمت، المديرين بتوع المستشفى اتكلموا قالوا وقف بقيه الليسته مش هنكمل. The BOA اللي هي British Orthopedic Association offered guidance throughout this period from the very beginning regarding the management of different orthopedic emergencies. However, one group of patients continue to present with similar frequency وهم دول elderly patients with fragility fractures mostly hip related ومعظم دول جايين من nursing homes وكلهم is a very critical group of patients كلهم جايين عندهم multiple comorbidities وبنتكلم على ASA 3 and above. From our experience في الفراكتشرز neck of femur, fracture neck of femur للي ما يعرفش عندنا هنا في انجلترا it's a surgical emergency. It's known to be contributing to a high mortality among patients if they are not operated within 36 hours. وكان في كذا protocol encouraged by the government إن كل العيانين دول they have to be operated within 36 hours. So this is an emergency. Patients often have multiple comorbidities. بنتكلم على COPD, hypertension, عيانين عندهم previous cancer history, diabetics, overweight, dementia, كل حاجة. During the last 8 weeks, our unit performed actually the number apparently طلع أكتر من كده is 112 cases. Out of these كان في a certain number زاد أو قل عن كده 13 patients with a pre-operative diagnosis of COVID-19 infection, whether this was confirmed via PCR أو radiologically confirmed. From other injuries, دول كان في ال threshold بتاعنا for operative intervention as per the British Orthopedic Association guidance was quite high, reserved predominantly for limb-saving surgery. limb saving surgery في العظم are acute compartment syndrome, open fractures, vascular injuries, coda equina syndrome. Majority of upper limb injuries were treated non-operatively. We do not deal with spinal injuries في التراست بتاعتنا high injury spinal injuries. We do not deal with them. فأنا ما عنديش experience مع القصة دي. إنما إحنا معظم الحالات اللي بتجيلنا في spinal injuries elderly patients with C2 fractures أو elderly patients برضو with vertebral compression fractures. ودول المajority بتاعتهم they get treated, almost all of them they get treated non-operatively. Going forward about البروسيس بتاعتنا بتاعت الديسيجن ميكينج, we are now contributing لحاجه اسمها surge COVID. Our unit is one of 200 and I would encourage everyone, it's not actually COVID surge, it's surge COVID ولا COVID surge actually صح. Our unit is one of 235 hospitals in 24 countries worldwide contributing to a global study on surgery during COVID-19 pandemic. وده اللي هيجاوب على السؤال اللي الدكتور علي كان بيسأله على المورتاليتي ريت. البريليمينري results on 1100 patients have just been accepted by the Lancet in an article called 30-day mortality and pulmonary complications in patients undergoing surgery with a perioperative SARS-CoV-2 infection. البيبر دي المفروض ان هي will be available free online within the next 2 to 3 days. احنا contributed للبيبر دي عن طريق العيانين بتاعت الفراكتشر نيك اوف فيمر. It's an ongoing study, ولما دخلت على الويب سايت بتاعت كوفيد سيرج في contributors من مصر. انا مش عارف اسمه ايه الصراحه, مش فاكر اسمه ايه, بس انا بصيت في contributors من مصر and we would encourage you ان انتوا كمان تشاركوا في القصه دي. Learning points from البيبر دي were discussed on a webinar, وده اللي انا جايبه لكم منه, ان ال 30-day mortality rates among patients having surgery في ال 1128 عيان is approximately 24%. Emergency surgery is 25.6% and elective surgery is approximately 18.9%. What was interesting, one of the interesting findings from this paper was that a pre-operative diagnosis of SARS-CoV-2 infection has led to a mortality of 21.3. يعني لو جاي لك عيان عنده داخل يعمل عملية ودايجنوز من قبل ما يخش يعمل عملية إن هو عنده COVID-19 infection, المورتاليتي بتاعته is about 21.3%. لو هو developed الانفكشن ده within the post-operative period وهو كان negative, he was negative, completely negative قبل العملية, بس he developed it afterwards, the mortality rate is 25.6, which means that the mortality is equal between the two groups of patients. And this is a shocking finding. The 30-day mortality was also analyzed by subgroups, okay? Whether the patient is below or above the age of 70 and the type of procedure being performed. I hope in the slide دي تكون واضحة لكل الناس اللي موجودين شايفين. As you can see, being a male above the age of 70, having an emergency major procedure carries a mortality risk of 44%. this is a huge number of patients being at risk of dying from the procedure. And this has had an impact on how we are consenting our patients, what we are telling them, and what we are telling our families, and how we are preparing for the surgery with the anesthetist, with the intensivist, what we are doing, and whether we should be operating aslan wala la. If you are looking at the risk factors for 30-day mortality, and this is something that would even give us a better understanding according to odds ratio, an emergency surgery carries a higher risk of death as compared to elective surgery by 1.67. A major surgery is definitely a higher risk. A post-operative diagnosis of infection زيه زي pre-operative diagnosis, there is no significant difference. يعني لو عيانك كان سليم he caught the infection while in the hospital, he's exactly at a similar risk to a patient who has had it before the surgery. Male patients, as we agreed, ASA grade 3 to 5. Trauma patients are similar to benign and obstetric conditions. مش معنى كده ان هم they are not at a high risk. لا، هو الكانسر patients are the highest risk of all patients. انما التروما patients are comparable للbenign conditions. learning points من process of decision making بتاعتنا ان احنا we had to raise our threshold for surgical intervention because of the high risk of perioperative mortality during the pandemic, risk stratification of patients, and a collaborative approach to decision making. Sometimes it's not just one person making the decision. I often consult one of my colleagues. I often consult an anesthetist, an intensivist. And when we speak to the family, we tell them about patients. أنت دلوقتي عندك risk to die from this surgery within the perioperative period, which makes it even worse for these patients in Oma. They are not allowed any of their family members around. And we had to go through painful situations where I was being contacted by people asking me to put them in touch with their family and put them on my phone and stuff like this. فالكلام ده هل هنقدر نترانسليت التجربة دي going forward ولا لأ؟ ده اللي لسه الستادي اللي هي اتنشرت دي، الكلام ده لسه الريزلتس دي بتزيد كل شوية. يعني الريزلتس دي are not finalized. وعشان كده أنا encourage everyone إن هم they contribute للستادي دي بالداتا اللي عندهم.
Thank you very much.
دكتور حسام كان في بول في الاخر انا ما سالتوش في الاول.
ممكن تساله بعد اذنك؟
يا ريت بعد اذن حضرتك.
اطلع لك انا كويستشن؟
يا ريت. لا ده مش هو ده يا بيه.
مش هو ده، ما انا عارف. يا جماعه حد يساعدني بقى في طلوع الكويستشن مظبوط عشان انا عايز ادي ان فولينج.
يا دكتور انا هختار الكويستشن
عشان انا بيطلع لي انا نفس السؤال.
احنا بدأنا الفوتنج للكويستشن الثاني.
اوكي. هو السؤال بيقول a 54-year-old patient presenting to A&E with fractured neck of femur. CT shows findings consistent with COVID-19 infection, but patient denies having any symptoms. Which of the following is correct? Operative treatment should be delayed until the patient tests negative by PCR. The risk of disease transmission to healthcare workers is negligible since the patient is asymptomatic. The risk of death to this patient from operative intervention is similar to other patients who are COVID negative, while the risk of death is similar to another patient who was COVID negative but then contracted infection 1 week after surgery.
يلا يا جماعه vote. We need to vote يا جماعه. يلا عدد قليل قوي is voting. يعني اعملوا غلطات ما فيهاش حاجه يعني. احنا we're taking a lot of time. طبعا التوكس are fantastic والدiscussions كلها جميله، بس احنا متاخرين جدا في الوقت.
طيب
Should we end the poll now? Let's end the poll.
Yeah.
I've ended the poll now. Ismail, do you have any comments on the poll?
طبعا I have في 5 people answered in operative treatment should be delayed until the patient tests negative by PCR. This is not right. وده اللي انا احب ان انا ابقى اكلمكم عليه بعد كده، ان احنا ما عندناش اي evidence بيقول ان احنا نديلي سيرجري لغايه ما البيشنت تيست نيجاتيف. There is a high risk of mortality كده. The risk of disease transmission to healthcare workers is not, there is no evidence برضو to tell us in risk of disease transmission is negligible عشان patient is asymptomatic، ولا in risk of death to this patient from operative intervention is similar to other patients who are COVID negative. الحاجة الوحيدة اللي صح ان هم زي ما انا قلت في البرزنتيشن بتاعتي according to our most recent evidence اللي بنتكلم عليه ان هو the risk of death is similar to another patient who develops infection post-operatively.
تمام دكتور علي. Any comments or question? Professor Hazem Abdelazim.
I just want from Dr. Ismail just to highlight is there is difference between the COVID negative patient and COVID positive patient regarding the outcome, or it is close?
ما نقدرش نرد على حضرتك السؤال ده carefully. اللي اقدر يعني ما اقدرش ارد عليك باجابه evidence based في الكلام ده. اللي اقدر اقوله كله ما نطلق عليه احنا anecdotal ده بمعنى ان انا هقول لحضرتك my own experience
اللي شفته
ان انا شفت عيانين خرجت عيانين من المستشفى 96 years old and above after fractured neck of femur treatment بعد ما عملت عمليه وكوفيد بوزيتيف وعندها multiple comorbidities and she was discharged من غير اي مشاكل. وشفت عيانين تانيين اصغر منها في السن وما عندهمش حاجه and they passed away. اللي احنا بنقوله ان الديسيجن ميكنج بروسيس بتاعتنا اتغيرت من حيث مش بس كوفيد بوزيتيف ولا كوفيد نيجاتيف، لا من حيث whether the surgery is essential اصلا ولا لا. يعني انا واحده من الحاجات اللي انا عديت عليها ان انا جالي عيان عنده recurrent dislocation of the hip of the prosthetic hip, a hip that has been implanted 15 years ago وحصل فيه wearing في البوليإثيلين بتاعه والهيب ابتدى يديسلوكيت، وكانت جت قبل البانديميك بحوالي اسبوعين واتعمل لها ريدكشن وكنا عارفين ان هي هتخلع تاني وكان she was being prepared for a revision surgery. حصلت البانديميك no revision surgery for the time being. جت تاني على الاي ان اي في وسط البانديميك كوفيد بوزيتيف ولا حاجه. we didn't even attempt to reduce لان احنا عارفين ان الهيب ده هيخلع تاني. العيانه دي we made sure ان هي she's comfortable. She was mobilizing bed to chair with the help of the physio and she went to the care home. She was followed up later. She's fine. Hopefully we will manage later on ان احنا نعمل العمليه. ف if there is an option for non-operative treatment whether the patient is positive or not at the moment this is what we are doing. احنا we do not operate on every single patient.
So indication is the most important issue.
Exactly. Life or limb saving.
Yes. Thank you.
عاوز اقول حاجه انا كمان تخص السبجكت بتاع البيشنتس اللي هم الامرجنسي ات ان elderly age وعلى راسهم طبعا فراكشن نيك عندنا. This patient is we consider it a kind of emergency وهو اساسا بيبقى دائما ابدا في comorbidities. قليل لما نلاقي حد في الايدج ده من غير comorbidity. فبنعتبر حسب كلام دكتور اسماعيل انه COVID-19 is one of these kind of comorbidities. كتير مننا بيقول البيشنتس اللي عنده مثلا هارت فيلير ولا بروبلمز من اللي هي ممكن كان بي يعني dealt with before and during surgery and after surgery والبيشنت يطلع سيف بنقول له ان احنا دي comorbidity which carries the risk of so and so and so and so. اعتقد نفس الكلام ده اللي بيتقال على الكوفيد حسب كلام الدكتور اسماعيل. وانا يعني برغم انها حاجه ريسكي حتى على السيرجن نفسه وعلى المستشفى والكلام ده، انما اعتقد ان ده is the right of the patient to take his chance لانه لو اتساب he is going to get يعني he may die even يعني.
طبعا وعشان كده اللي احنا بنقوله ان هو patients even if they die they have to die in dignity. يعني patient being in the auto unless احنا we ended up not operating on a couple of patients but these were patients who were terminal. Patients had a very low oxygen saturation. They wouldn't even tolerate an anesthetic. And if the patient tolerates anesthesia there was no indication whatsoever to go ahead with the surgery on a fracture of neck of femur.
شكرا دكتور حسام.
شكرا سعاده البيه. شكرا دكتور اسماعيل. Our third question Professor محمد المشتاوي. You should ask the third question. دكتور مشتاوي اتفضل.
Thanks Sam. First of all it is a great pleasure to me to be with you today, especially under the tent and the chair of our greatest glorious Professor Hazem Abdelazim. And I welcome all colleagues from UK, Fadi, Amgad, and others. And my question to Amgad Nakhlaf, who did know, he is a consultant of orthopedic surgery in James Badgett University Hospital. Amgad, please, you were one of the lucky ones to catch this terrible disease, I know, early on during this pandemic, but thankfully you managed to pull through. Can you tell us your experience with this COVID-19 circumstance?
Thank you, Professor Mohammed. Thank you for all my professors and colleagues. I will be as concise as possible. I'm a lower limb consultant. Like in today, I will take the patient's role. I had my COVID-19 came very early on, before the lockdown in the UK. We were all still not aware of how mild it can be. كان يوم 13 مارس, and I had my elective list with a few joint replacements to do on it. ابتديت الصبح شفت العيانين بتوعي as usual, وابتديت أكح كحة خفيفة أوي. The very light cough that I had did not go with the guidance as a continuous or persistent cough, which is not very clear guidance. I spoke to one of my colleagues, وإحنا الاثنين حسينا إن إحنا ممكن نطنشها. It's very simple cough. Like, because of the circumstances and what we've been hearing from China and other places, we thought at least I should get my temperature. كانت 37.4. We felt that's okay. Carry on with my list. ابتديت الأول عملت first total knee replacement, and I was perfectly fine. مش حاسس بأي حاجة غلط. After I finished, I got my temperature again. كانت 37.4, 37.5. Again, we thought the coughing is very, very mild. Just carry on and do the list. I did the following total hip replacement. I didn't feel any changes while doing it. بس أول ما خلصت قست حرارتي تاني, and it had shot up to 38.5. ساعتها I left immediately. I put a mask on and rushed through the hospital. I didn't want to speak to anyone face to face. وخرجت من المستشفى. بعد كده كلمت ال occupational health وال department manager, وقلت لهم إن I had to leave, and the rest of my list got cancelled. From there, I spent 4 hours on the phone to try and get tested, because the tests were not available at that time generally in the UK. So I managed to arrange it through a drive-through center. I drove with my car. I needed to have the mask on while coming in, وحطيت على العربية مكتوب من قدام اسمي وتاريخ ميلادي بس, so that they let me pass. والصورة زي ما شريف ورانا قبل كده, جالي حد في full PPE to take the swab from my nose and my throat. They took the swab. كلمت مراتي وأنا مروح في السكة so that I fully isolate, and I isolated لدرجة إن أنا كنت قاعد في a completely different apartment on my own. مراتي كانت بتعمل لي الأكل وتسيبه لي بره الباب. I wasn't even seeing my family except in outdoors, and we were very strict that the kids didn't come more than 2 meters close to me. We were talking to each other from a distance. الحمد لله أول يوم كان فيه الكحة الخفيفة and the very light temperature. Second day, again, very mild cough and no temperature. But what was interesting in these 2 days was very, very distinctive headache, not like any headache I've had in my life before. And I can't really describe it, but it's something throbbing in your head, not like the normal headache that we can get from other causes. ثالث يوم, I didn't have a temperature nor a cough, and by the evening, suddenly my headache disappeared, and I felt I'm back to normal. And I can't explain that, but it just suddenly, miraculously, everything disappeared, and I felt that's the end of it. الريزلت عشان ساعتها برضو كان لسه التست not available widely, فأخذوا 5 أيام until they came back to me with the results, which was positive. Even after my symptoms disappeared completely, I carried on self-isolation from my family. لكن in the 5th day, they started developing symptoms themselves. but I moved into them into the flat with them then. We felt that there's no point of self-isolating from them anymore, but I self-isolated from everyone else, and we all stayed indoors. The guidance from the UK then was once you have your symptoms, 7 days and you can go back to work if you don't have a fever, but even if you have a cough, you can go back to work. So on day 8, I was back to my trauma week, and I carried on working for the whole week. But alhamdulillah, it was all very mild, and me and my family, we all recovered from it fully.
Thanks, Amga, for that. In the same context, I have one of the questions of the attendees. Dr. Muhammad Abdelal, he is asking which one of the symptoms more important and critical? Is it sore throat or rhinorrhea or fever, Amga? What do you think about it?
Rhinorrhea is not common at all. I don't think even it's considered a symptom. Like in a fever, with sore throat, they come in to variable extent. And now one of the most important symptoms now as well is the disappearance of the sense of taste or smell. Some patients don't have any other symptoms. They don't get a fever, they don't get a cough, they don't get a sore throat, but so they just lose their sense of smell and taste.
Yes, thank you.
Thank you.
Hussam, I can shift to another question.
Yes, كان في الدكتور محمد عبد العال wanted to ask a question. I think we better give him a chance. Dr. Muhammad Abdel Al, I have unmuted you. You can unmute yourself and ask your question, Dr. Muhammad. I have unmuted you. أنت unmute yourself وتفضل اتكلم.
He's unmuted now.
صوتك كده مسموع؟
سامعينك. أيوه.
هو كان سؤالي على زي ما الاستاذ دكتور حازم عبورين قال ان بيضاف الى الكوموربيديتيز بتاعت العيانين اللي هم ليهم حاجه ايرجنت، كمان الكوفيد بتعتبر واحده من الكوموربيديتيز. سؤالي بقى، هل بتختلف او بيختلف المريض اللي عنده فراكشر نيك فيمر عن العيان اللي عنده ابندكس، عن العيان اللي عنده هيعمل حاجه ثانيه في اي جراحه ثانيه، ولا يعني هي تعتمد على الجراحه ولا تعتمد على هو في اي مرحله من مراحل الكوفيد؟
انا هقول لحضرتك ماي انفورميشن، بس شيف هيجاوب على سؤال الابندسايتس ده احسن مني، بس هقول لحضرتك برضه لو احنا هنجاوب ايفيدنس بيزد ان هي معتمده على whether it's هي minor or major surgery وكذا ريسك فاكتور تانيين، ASA جريد، الجندر بتاع العيان، كل الحاجات دي بتكونتريبيوت. انما انا متاكد ان الدكتور شريف هيجاوب على حاجه دلوقتي مثلا في حاجه زي الابندسكتومي، ان هم في كتير قوي عيانين بيتعالجوا دلوقتي نون اوبراتيفلي انتي بايوتكس. وفي البيبر بتاعت الكوفيد سيرج اللي كنت بتكلم عليها، لما جم يتكلموا يقولوا ان في ناس، في دكاتره في المكسيك طالعين في الويبينار بيتكلموا بيقولوا احنا we have no experience in treating appendicitis non-operatively، ما احناش عارفين نعمل ايه. فانا I will pass this on لشريف. بس الحاجه الثانيه، احنا عندنا في العظم all upper limb injuries were treated non-operatively with the exception of 2 عيانين elbow fracture dislocation، عيانين ankle fracture dislocation، عيانين tibial plateau، انما معظم ال upper limb injuries كلهم كانوا بيتعالجوا non-operatively.
I have to say على ال upper limb injuries, one of the injuries that's considered most people operate on it here is volar Barton, for example. بس thanks للقصر العيني I think ان احنا الوحيدين تقريبا هنا اللي متعلمين ازاي نقدر نرجعهم and manipulate them properly and put a proper plaster. ما حدش قادر يستوعب حكايه ان you need to flex the wrist with a volar Barton when you immobilize it. كل الناس بتحطهم in extension when they do it and they slip.
طب هتقولي شريف؟
لا انا هقول تعليق سريع جدا. شكرا محمد على السؤال. هو احنا عندنا الجايدنس بتاعت الرويال كولج اوف سيرجنز باختصار شديد، هو لو نقدر نمانج حاجه كونزرفتيفلي مانج ات كونزرفتيفلي. طبعا الموضوع اتاخد بقى تو ذا نكست ليفل شويه، ان الجراحين خايفين بمنتهى الامانه في الاول لما الارقام زادت جدا، على شويه استعباط يعني الناس اللي كانت عايزه تقعد في البيت ما تشتغلش. فيعني بصراحه حصل ان تم عمل حاجات مش كويسه قوي يعني، بالذات مع الزوايد والابندكس. انتي بايوتكس ويخف، ونستنى السي ار بي ينزل من 126 ل 102 نقول كده العيان اتحسن ونروحه نخرجه بقى ويبقى مسؤوليه حد تاني في شيفت تاني. الحقيقه حصل. ولكن في التروما حتى كمان قالوا لنا try to utilize intervention radiology as much as possible، مثلا embolize spleen بدل ما نشيله وكلام من ده. فمينلي it's conservative لو نقدر نعملها. اهم حاجه بس طبعا ان احنا ما نخسرش العيانين دول كانوا في الفولو اب، ولكن الحقيقه ده مش يعني انا مش شايف شخصيا صح، بس طبعا هي دي الجايد لاينز اللي احنا ماشيين عليها. النقطه اخرانيه خالص هقولها سريعا، ان هو حصل اصلا دروب في عدد الحالات. يعني احنا on a normal day كان بيخش لنا 6 أو 7 زوايد في اليوم نعمل عمليات على 4 أو 5 منهم on average، دلوقتي بقى بيخش لنا 2 والاثنين مفرقعين محتاجين عمليات. فيعني قصدي الموضوع بقى مبين نفسه زياده عن اللزوم.
Exactly. Threshold of going to the A&E is actually much higher, therefore you get less load. بدي فرصه لاستاذنا الدكتور محمد مزيد. اتفضل يا دكتور محمد، اسال سؤالك يا باشا.
شكرا. انا thank you for every person in the panel and our guest speaker. My question was that we are obliged. I was in a panel with our Indian friends, international faculties also mixed meeting, and this was my opinion and they accepted it. I think they came the same advice coming from UK also, that as an orthopedic surgeon in general, we have to minimize the indication of our surgery. Don't do everything by open surgery. Try your best to use closed technique, image technique, K-wire reduction, and the only thing you can deal with openly if it is compound fracture lacerated injury or fracture neck femur, which is very important, especially with patients with comorbidity. But we can shift to minimally invasive intervention, doing the scopic techniques. All of this can help us to save patient and avoid complication to our patient as a result of our extended time surgery, because big surgery is risky for the patient with morbidity. It is more risky for patient with COVID. So COVID is serious addition of the morbidity, not just added number to increase the number of morbidity. It is very serious morbidity because to have for this for 25% of our patients, because just for this reason is very disaster. So we minimize our intervention, and thank you for our advisor from UK, and thank you for Dr. Hazim, my great friend, and Dr. Hussam, and all of my colleagues, Dr. Koptan. All this I understand more why
Thank
we
you
are
very
stayed
much,
home.
Professor Mazin. God bless you. Thank you very much for your comments. I think we are running out of time. We better just move on. Question number 4. Professor Mohammed Al-Mishtawi will ask the question.
Thanks.
Dr.
Fadi Sidra. Fadi Sidra is a consultant of orthopedics and spine surgery in Royal London Hospital. Actually, Fadi, your team has been redeployed to manage minor injuries in accident and emergency department. Can you please tell us about your experience with managing this section of accident and emergencies, but also how you manage the clinics during this crisis, please?
Thank you very much, Professor Mishtawi, for your question. I would like to thank Professor Hussam for this wonderful opportunity. I'm deeply honored to be amongst my professors with Professor Hazim Abdulazim on top, of course, as a chairman, and all my mentors. Let me share my screen. So as you kindly said, Professor Mishtawi, I work at the Royal London Hospital, which is a major trauma center and a hub in the northeast part of London. We have more than 700 beds. Unfortunately, we were heavily hit with the COVID patients, with the COVID pandemic, with many patients arriving at A&E. And I think it is also my colleagues' experience in that the orthopedic department took over the A&E minor injuries. And just for everyone's benefit, the A&E minors, they handle injuries like sprains and strains and limited burns, cuts, fractures, and so on. Obviously, we had help from a subset of qualified nurses called extended nurse practitioners who were of great help, but obviously we had to go out of our scope in removing foreign bodies and dealing with burns and slight abdominal pains and so on and so forth. We had to put a process in place in order to, as Sharif said, to protect the staff and protect the patients who do not have the infections from the patients who might be carrying the virus. So very briefly, we've put a process guided by the guidance from the Royal College, where the patient checks in at the receptionist, and then the receptionist would ask the patient if they had any respiratory symptoms or temperature. If the patient had no respiratory symptoms, normal temperature or temperature, they would wait in the normal waiting area. If the patient had any respiratory symptom or any temperature, he would be handed a mask and asked to wait in a designated area. And then the receptionist would inform the clinic staff that there is a patient with a suspected COVID infection waiting there. And then for the patients who are waiting in the normal waiting area, whenever they are called to the examination room, they would have their second screening, where we would take their temperatures. If their temperature was less than 37.8, then they would go into the treatment room or into the examination room, observing obviously the guidelines of social distancing. If the patient had a temperature above 37.8, then he would go, he would be redirected to the same designated area where the clinician would review the history and review the images of the patient if he had any orthopedic problem, and make a decision. If it is an urgent, has to be seen, then the patient would be guided to a different clinic room or a clinical area where he would be reviewed by a clinician. Obviously, we try to reduce the number of healthcare providers as much as possible, and also provide them with full PPE. If it is not urgent, and this is a decision that the clinician has to make, then the patient would be scheduled to come back to the hospital whenever the symptoms subside, but not less than 7 days. So this is the process that was put in place. But when it comes to clinics, obviously, at that point in time, particularly when the lockdown happened and during the height of the pandemic, we couldn't have the normal clinics where people would be queuing and the waiting area would be very busy. This was just not doable. So we had to close down the elective clinic. Normally in the UK, the clinics would be triaged or prepped by one of the junior staff, mainly the registrars. But because of the circumstances, the consultant had to triage the referrals and the follow-ups and vet the clinic himself, and decide to either cancel all non-urgent clinic reviews or defer them to a later date. The GP, so the referral pathway in the UK starts from the primary care, where the GP would refer to the secondary care. So unfortunately, we had to reject all GP referrals from outside our catchment area, and we would reject with a either an advice on how to possibly manage the patient. And also, before the pandemic, we were talking about using some remote consultation softwares, but obviously because of the current circumstances, this has we rushed the process a bit, and we brought remote consultation softwares where they are different, including the one that we're using now that can be used. Obviously, they had to pass an information governance process and have to have an end-to-end encryption and so on and so forth. And this is a screenshot of the remote consultation software that I use, where you can see there is a waiting area for the patient. Obviously, I understand that it might not be possible to do it or to use it by all clinicians, but at least part of the patients who could have their consultation virtually, we should be using it. Now, the question is, now we are after the peak. Very quickly, I will share with you the thoughts that we are now discussing on how to restore back our clinic reviews. Obviously, my advice is that everything must be done gradually and slowly, and guided by the guidelines. Number two, we've instituted the same screening tool that we used for the A&E minor injuries, in which the patient has a questionnaire and then temperature taken. Number three is to continue with the virtual consultation as much as possible. And we are now, obviously, it is a change of culture. It is a new norm. I think it would be difficult to get all the clinicians at the same time to use it. But the advice was that we need to continue use it even after the pandemic plateaus or stabilizes. It's very important to align with other services like radiology. It's no point restoring the service and then bringing the patient across with no x-rays available, or physiotherapy or occupational therapy or orthotics support. So we have to align with other services. It is very important to stay in touch with other units and benefit from their experience. So we have a collaborative, we all the time communicate with other units up and down the country because it's no point to reinvent the wheel. We see the steps that they've taken and their outcomes, and try to apply it. And at the end of the day, we need every day. The condition, the circumstances are so fluid. There are new guidelines, new papers, new evidence coming out every day, and it's utmost important to maintain ourselves updated and at the cutting edge of information when it comes to COVID. Thank you.
Thank you, Fadi, for this.
Can I, sorry to interrupt, can I just run the poll question very quickly?
Yes. Dr. Ahmed, can we have the poll question, please? Poll question number 4, Dr. Ahmed? Yes.
So my question to my colleagues is, what changes should we institute in our clinics? I encourage everyone to...
Should staff and patients all wear surgical masks? Questionnaire for all patients about possible symptoms, measuring patients' temperature, provide PPE for the staff, all of the above or none of the above. Okay, I think we end the poll here, Dr. Ahmed. So what do you think, Fadi?
I totally agree. I mean, the only point that is there is that it has been updated that the staff and the patients wearing surgical masks is important. Maybe we should consider that even the patients that are asymptomatic should be wearing surgical masks in the waiting area. Questionnaires, temperatures are a must, and PPE for the staff should be available. Otherwise, the service cannot go ahead. Thank you.
Well, thank you very much. Thank you, Fadi. Dr. Mishtawi, do you have any questions? Professor Hazem, do you have any questions to Fadi?
Yes, Fadi. My question about the telemedicine for follow-up follow up your patients. For how long this will continue, in your opinion? I ask this question because everything is confounding. Now we didn't know when to return to our baseline.
Thank you very much. Great question. So, as I said, it depends. Number one, it's very important to follow the guidance from the government. So far, we had a sort of a green light that emergency or urgent patients could be seen in clinic, but still the rule here is to reduce the footfall in all clinical areas and to use the virtual consultation as much as possible. And for the time being, patient coming to a clinic should be the exception, and only if on an urgent basis. For example, I'm seeing 2 patients next week. One of them, she had a sudden pain after 6 months of scoliosis correction, and the second patient with a slightly similar condition. And because I think in the UK we're slightly ahead of Egypt, and things are slightly coming down, so there is a personal decision that needs to be made, but guided also by the institute that we work in. Again, with regards to the virtual consultations, I agree it's not possible to use it all the time, but for patients who are followed up post-op surgery or follow-up, for example, scoliosis, I get them to have their x-rays done, and then I can follow up with them virtually.
Thank you, Fadi. That's a very comprehensive answer. Let me just say a couple of words here regarding, we don't have telemedicine formal software or anything, but you can use phone conversations. I do that all the time with patients who have acute back pain, which is acute back strain. They don't have to come to a clinic to see me. I can give them some medicine over the phone. Patients for follow-ups, I can get not just their x-rays on WhatsApp. I can actually take clinical photographs, sometimes videos for range of movement, or for I want to assess their gait. I get videos for that. So you can actually use a lot of these things to help avoid contact with patients.
Exactly.
Thank you. Well, we're getting short on time, so we better go ahead. But before we do that, I forgot to thank our host and our host, Elixir Pharma. Elixir Pharma is an Egyptian shareholding company that has penetrated the Egyptian market very recently in 2018. They actually produced the first generic ricoxib that we commonly use in managing acute and chronic pain. So thank you, Elixir Pharma, for giving us this opportunity to meet with these wonderful people from the UK. Professor Wael, you're about to ask your question number 5.
Yes, let's proceed again. Back to Dr. Sherif Haqi. Dr. Sherif, you previously shared with us your experience on PPE in a previous video. Can you please give us a broad idea on different types of PPE for different situations, and some tips on how to don on and don off safely, please?
Thank you very much, Professor Wael, for the question. I think it's a very important question. I only have 2 slides to show because I want to stick to time. And most of us by now have been able to do we've put on PPE once or twice before, all of us. So this is the slide that I really want to show. It is about mask fitting, right? Not every face has the same face structure or the bone structure, and not every mask is suitable to every face. And that is why if we think that we all wear an FFP3 mask or all wear an N95 and we're protected, we aren't. It is very important that we put on the mask and do what we call the mask fitting test. This is something that was compulsory for me, Amgad, Fadi, and Ismail to do. And I advise everyone to try to do it. It can be done in a very simple way. Basically what we do is we put a bag around, I wear the mask and I make sure the mask gives me a tight seal. And then I put something around me. This is it's like a bag, a plastic bag. And in the space between both, there is something with a scent. I even asked one of our microbiologists in the hospital if it can be used without this specific formula. And then he said, use lemon juice or use a strong perfume. And it's very important that one stays in the space and makes sure that he's unable, otherwise he will falsely think that he's protecting himself. So it's very important that the different face masks are trialed. This is one point. And the other point that I would like to say is that the donning, putting on PPE and the different types of PPE, this is something that's very simple to find out. One can do that. It's just the taking off of the PPE that is a bit tricky. So I've broken it down into those few photographs to just explain. This is on the first one. I don't know, can you see my cursor or am I only one seeing my cursor? I'm just going to be very brief. Yes. Just finished an operation. I head to the sterile bit, to the waste bin inside the theaters. And the first thing that we do is that we take on the first layer of the double gloves. As you can see, he's already taken his left glove off and he's left with the green. This is my colleague, James Kinross, and I've asked him to use those images. Then after every step, you have to use alcohol gel. Someone has to be in assistance. This is our surgical registrar, Jasmine, and she's here just to demonstrate. She's just putting the alcohol gel for James to use in between the steps. James then approaches the lower end of his gown and plastic apron, rolling the apron outside to the gown. So he is not touching his gown at any stage with his clean gloves. Remember, those green gloves are clean. And he rolls it up. He bends forward towards the bin and pulls the rolled up gown. And at this stage, actually, what happened is the green plastic apron, that's in the video, the green plastic apron didn't pull when he pulled. He kept pulling and pulling, and it just would give. And our registrar, again, Jasmine, came and undid this bit for him. The one thing that is really wrong in this video is that, or in these images, is that Jasmine, his assistant, should be also wearing her things. But this is just for demonstration. She should be in protection, but not full PPE, because this is just to help him doff. After that, he puts alcohol gel, and then he takes his visor off, bending forwards, not touching any of its outside. He's just touching the strap. He then walks out of the theater space, still in his N95 mask. James is fit for an N95. For example, I wear an FFP3. And then he bends forward and touches the outside of the mask and throws that into the bin directly. There is a suggestion that you should be wearing two hats so that the outside of the mask at this final step is not in the theater space, particularly for aerosol generating procedures, for example, in our practice like laparoscopy. But again, this is perhaps it's safer to wear two hats. And these are my slides regarding that, because everything else has been tried and tested. And again, I have a simple question to Paul for the panel. And this, I believe, is my last question. And I just have to say thank you very much for the opportunity to be amongst this panel. Thank you, Professor Hazem and Professor Hussam and Professor Wael and everyone else for having me, Professor Muhammad. I really enjoyed it. Thank you very much.
Thank you very much, Sharif. Now we go for poll question number 5. Dr. Ahmed. Poll question number 5, Dr. Ahmed. Yes.
So on doffing of one's PPE, when you remove your personal protective equipment after the operation, after operating actually on a COVID positive case. And then the options are: doffing can be safely carried out inside the same operating room that the surgery took place in, whilst the patient is still in the same OR. The patient Lissa is still inside the OR. Alcohol gel, appropriate disinfectant, or an appropriate disinfectant needs to be used after every step. You should not be helped by the circulating OR nurse. The face shield cannot be reused even if it is appropriately disinfected. The FFP3 or N95 mask can be the first item to be doffed.
Please vote, gentlemen.
Thank you very much for those who have answered. It really is another simple question. We should be using alcohol gel or any other appropriate sterilization formula after every single step that we do. And we cannot doff completely inside the OR, because you have to leave the mask and the hat until you walk out of theaters. you should actually be helped by someone. There should be someone holding the alcohol gel and helping should something get stuck. And the face mask is the last item to be removed. The face shields, some of them are reusable and they can be disinfected with quite a few things. I know that hydrogen peroxide in its liquid form is readily available in Egypt, and it's one of the best disinfectants for this cause. Thank you very much.
Thank you. Excellent. Can we just end the poll, please? Yes. Thank you. Fantastic. Okay. Well, thank you, Sharif. Any questions to Sharif, ya Jama'ah?
Yes, can I ask him a question, Hussam?
Please.
Sharif, is there a difference in the level of PPE protection if you're doing surgery on a patient who's a confirmed COVID positive and a patient who is not at these difficult times? And my second question is there a difference in the PPE protection if you're doing surgery for a couple of hours, or if you are in the ICU taking care of patients with COVID disease?
Thank you very much, Professor Wael, for this wonderful question. It's $1 million question, really. And I can see that Amgad was nodding his head for the first question, and I'll explain why. So for question number 2, to start with, there is no difference in PPE for caring for a COVID patient in the OR, in ITU, in A&E. Our A&E consultants are wearing this most of the time. There is no level of difference. If it's 1 hour, if it's 2 hours, if it's 12 hours, I did 2 intensive care shifts. One of them was a full 12 hours. I was in full PPE all the time, and it really is something. If we, the surgeons, complain, the ICU physicians have to, they really are the warriors of this battle. Answering question number 1 is that there should be no difference in what level of PPE you're wearing if you are operating on a COVID positive or a query COVID case. Of course, if this patient is COVID negative, meaning that you have done your PCR and it's negative, and a chest radiograph of some sort, preferably a CT scan, and the patient prior to this surgery has been isolating for 7 days, then you are safe. The patient is safe and you are safe. It can be back to the old days, but that's not what we're supposed to do. But for query COVID cases, in the case of an emergency, for example, the neck of femur example that Ismail has mentioned, if we don't know, then we deal with this patient as a COVID positive patient. Ismail is going to be closing at the end with a few remarks, but I'm just going to say that I attended a webinar some 6 weeks ago with the Italian surgeons who were at the height then. And they told us the one take-home message that you can take from this webinar is that the non-COVID patients and the query COVID patients are the ones that you should really be afraid of, not the one that is confirmed, because the one that's confirmed, you're actually going to be taking all your precautions. Just don't be too casual about the other ones. Thank you very much.
Excellent answer, Sharif.
Thank you very much.
Thank you very much, Professor. Thank you very much, Professor Hussain.
Okay, we're running short of time again, so thank you, Sharif, for your concise and very clear messages. Question number 6, unfortunately, Dr. Ali Bamadawi had to leave us, so I will have to take on his question and ask.
Ismail, unmute.
Yes, I'm going to ask Ismail, yes. Ismail, you had the chance to operate on many trauma patients during this crisis. Can you please tell us the protocols you follow for theater setup, patient positioning, and precautions during the actual procedure?
Yes, and I'm very glad this question is being raised by the panel. We agreed that this is what we would be discussing. It's a very important thing to understand no matter how chaotic the external environment could be, and I understand because we're all on social media, we understand what's going on in Cairo and what's going on in Egypt in general, that there are no clear restrictions as things are like here. We're here in England, we're in total lockdown. However, you people in Egypt, healthcare professionals in Egypt have got a huge responsibility, a massive responsibility on keeping things organized. No matter how chaotic things are like outside, you have an absolute responsibility for your patients and for your colleagues and for the staff in general, okay? What I'm going to share with you again is our experience during operating. I've operated about, I would say about 50 patients, again, give or take. First of all, some of the slides in my presentation, I'll go through them quickly, but they are important to make everyone understand what we're talking about. A patient presenting to A&E, we have our own setup at the hospital where there are dedicated wards to different groups of patients. This is the single most important thing. There are asymptomatic patients without a diagnosis of COVID-19 infection. There are COVID-19 positive patients, whether they were diagnosed as positive before coming to the hospital or whether they were diagnosed by CT scan findings. Although I must say that where I work, we haven't relied massively on this. Majority of patients coming with a fractured neck of femur have come straight either from their homes or from the nursing homes. These will fall mostly into the third group of patients, which are suspected patients who are awaiting for results of swab testing. The decision-making, again, was a high threshold for surgical intervention will risk stratification. We perform always surgical procedure that would allow immediate weight bearing. There has been very, very little place now to, for example, cannulated screw fixation and fractures of neck of femur with limited weight bearing afterwards. Each patient is getting a cemented hemi. The consenting process was from the very beginning. We involved everyone about the family. We have to discuss things about resuscitation requirements and the patient's wishes. And this is very important because we've got two levels of care for these patients. One of them is called ward-based care. So if the patient arrests, whether he's COVID positive or COVID negative, it doesn't make a huge difference. Even if it's COVID negative, we have to be aware of this. If a patient arrests during surgery or afterwards, what is it that we are going to do? Is this patient going to be transferred into ITU? And you send him into ITU, probably there won't be enough beds. Now there are some beds, but the other thing is he will catch the infection inside the ITU. I know that this is a slightly debatable issue in Egypt. I'm not sure whether we are allowed to discuss this or not, whether patients are given the option of allowing them to resuscitate or not, but we are given this option and patients are given the option of do not attempt to resuscitate. And even if they lack the capacity for this, they must have discussed it with someone else. Sometimes we make the decision joint with the family. And it's very important that everything is being documented from the very beginning. The philosophy beyond our operating this is an emergency surgery with little or no time to clearly identify positive patients. Accordingly, just like Sharif has mentioned, if in doubt, every single patient is treated as positive. And we also know that orthopedic surgery is an aerosol generating procedure. Most of our procedures, if not all of them, apart from carpal tunnel syndrome, maybe carpal tunnel decompression, is considered an aerosol generating procedure with a high risk of disease transmission if the patient is positive. The main aim is to minimize the risk of exposure to the patients and staff, but predominantly staff. While we are talking about the theater, we all panicked. Today, it has been announced that 181 healthcare workers in the NHS have sadly died during this pandemic. This is a huge number of doctors. Our theater areas have been defined, and when I say the theater area, I don't mean the entire theater suite, I mean each theater unit. Each theater unit has got the operating room, the anesthetic room, and the scrub room. These are divided into a green, amber, and red. And the amber zone is an area which is a transitional zone. The green zone throughout the whole procedure is the anesthetic room. This is considered as a green zone. There is no infection in there. Nothing infected is allowed to get in there. The theater is initially green, but then turns after the patient comes in and becomes anesthetized into a red zone. The scrub room is initially green. After you come into it, after finishing surgery, it becomes an amber zone. Another very important point is that every single person should be protected. It's not a one-man show. It's not that a surgeon and the anesthetist, or the surgeon or the assistant, or the surgeon, the assistant and the nurse. Every single person within the operating room should be protected, as in wearing full protective equipment. The theater team, we meet in the morning. We meet after we've decided on the list. We do a team briefing as we usually do, discussing the patients that we have. The teams include a surgeon and their assistant, an anesthetist and their assistant, a scrub nurse and a circulating, or the runner nurse, a radiographer, a runner outside the theater, and a nurse involved in donning and doffing. And I'm quite glad that what Sharif has said, that Sharif's talk has come before me, rather than having to explain what this is. With regards to the PPE that we wear in theater, all personnel inside the operating theater, whether they are dealing, as I said, with a COVID positive or a COVID negative or suspected, should be wearing a FFP3 mask. With mask fitting is essential. Having said this, there is recently, and I'm not sure whether this is something that will be available in the market in Egypt, Stryker has come up with a hood which is different from the hood that we wear during arthroplasty, with a valve in it that will prevent infection. However, if you are using an FFP3 mask, it's best that this gets fitted. There are no beards allowed underneath the mask. Any mask that you wear with a beard is less protective. You should be wearing goggles, and if you're wearing a valve mask, a visor should be covering the valve, okay? Otherwise, the valve gets damaged. You're wearing a gown, and you're wearing the gloves, okay? And there are certain additions to that. Personnel, I'll add the additions later on, but this is the basic that we will be wearing. The personnel outside the operating theater will be required to wear a surgical mask, just a regular surgical mask, gloves, and a plastic apron. Now, the first thing that happens before we call in for the patient is that the scrub nurse is the first that goes into the theater. She goes by herself, not wearing any FFP3, just scrubs up, wears the regular masks. She opens the trays, make sure that everything is sterile, make sure that everything is complete. Once she makes sure of that, the trays are covered and the green light is given to send for the patient. The patient is then brought directly into the operating theater, okay, bypassing the anesthetic room completely, which is our green zone. This will remain our green zone. Anesthesia proceeds as standard. And once the patient is anesthetized, the green light is given to the surgical team to go and scrub up. The surgical team goes into the scrub room, scrubs up, wear their full PPE, okay? But in addition to that, we wear a double gown, which Sharif has actually shown again in his picture. The reason why we wear a double gown is that we are minimizing traffic within the theater. There are no healthcare assistants who position the patient. There is nothing called, I need an extra person to mobilize a patient with me. I am the one who's going to position the patient. Sometimes there are two consultants scrubbed. We are the ones who position the patient. There is no one, because we want to limit the amount of PPE being used. So we position the patients ourselves. Once this has been done, we discard the outer gown and proceed with surgery. With regards to the surgical procedure itself, if you have decided to operate on a patient, there are very few changes, if any, from what you would do normally during the procedure. For example, one of the things is that we currently do not use pulse lavage when we're doing hip replacement, hemiarthroplasty. We just use normal saline irrigation because the pulse lavage is considered as more aerosol generating. There has been talks about the use of diathermy. However, with the use of the FFP3 mask, this is becoming less of an issue. We use absorbable sutures at the end of surgery to minimize the post-operative visits. But again, the most important thing is that there is no traffic in or out of theater during the procedure, none whatsoever. When I ask, for example, I'm doing a hip hemiarthroplasty, and I ask for a size of stem 37.5 number 1, and you ask for this, okay, the inside runner asks the outside runner through the anesthetic room for the necessary implants, and these get handed through the anesthetic room. Expedited surgery, but without hastiness. I remember being involved in the very first few surgeries after this pandemic, and I was panicking, I was running things up, and there is no point. You are adequately protected. What is more important is what comes next, and fortunately, I do not have to explain this again in detail since Sharif has explained it, because upon completion of the surgery, remember that the operating theater is now potentially studded with virus-containing aerosol. This is exactly what's happening. You've generated aerosol from your procedure. If this patient is breathing out virus, then you should not just simply take off your gown and mask. What you do is that you discard the gown from inside out without touching it and dispose it in the bin. You get out of theater completely into the scrub room area, which is now the amber zone, and practice doffing carefully as described. Discard your surgical. Once you finish this, you finished washing yourself up, you go into the scrub, into the surgical changing room, you change your scrubs and wear a fresh pair for the subsequent surgery. The theater cleaning has to commence after the patient leaves the theater. The theater team should do that, not another person coming from outside. The theater team in their full PPE. Remember that the theater is still full of aerosol. The theater is cleaned thoroughly as per the hospital guidelines. After 30 to 40 minutes, the theater is considered to be safe for use again. With regards to the post-operative care, we use standard post-operative antibiotics and VTE prophylaxis unless the patient is COVID positive. There are currently no approved therapies for COVID-19 in the UK, and experimental treatments, including chloroquine and hydroxychloroquine, are restricted to clinical trials. We're not using any of this. We've come across patients with post-operative pneumonia and fever. And although we know that COVID-19 is a viral infection, there are overlapping clinical and radiological features with bacterial respiratory tract infections. So it is inevitable that antibiotics will be prescribed for many. We should be considering antibiotics in those where bacterial infection cannot be excluded, COPD exacerbations with purulent sputum, or when there is a radiological evidence of pneumonia. Unfortunately, CRP cannot be used to diagnose anything because COVID-19 causes a raised CRP and does not predict bacterial co-infection. We've got guidance. The antibiotics that we are mostly using are doxycycline, coamoxiclav, clarithromycin, and in severe pneumonia, levofloxacin. The first three I've mentioned, these are options. You use one or the other two. I'm happy to share these, but I'm sure that you can find these. This is a suspected community-acquired pneumonia, which is a different condition from the hospital-acquired pneumonia. This is a patient who's developed pneumonia after the surgery. The first one is a patient who's come into the hospital with pneumonia. How are we going forward from here? Now the NHS England is publishing guidance regarding what will happen next. Initially, we wouldn't swab every single patient coming on. Now, on arrival, ensure patients are immediately, if you look at the right side of this table, patients will be immediately identified. This has always been the case, but we're now swabbing patients as soon as they come in. Ensure within the emergency department and urgent access clinics that asymptomatic patients can comply with normal social distancing requirements. This is very important. We do not hang out together anymore like we used to do in doctors' waiting area. Ensure any patient who subsequently tests positive or shows symptoms can be immediately isolated or managed in a COVID positive cohorted area. This is especially important in a place like Egypt. We've got hospitals, private hospitals, where some of you are operating. The hospital need to make sure that there are certain areas which are completely isolated. These are for patients with COVID positive. The last thing that we want is for patients to cross-infect one another. There should be an enhanced planning and protection for patients who are clinically extremely vulnerable, and these should be shielded. You've got a patient who's 89, these should be shielded. There is another element about elective work. My colleague Fadi will be talking about it. All patients should be tested on admissions. Upon discharge, patients should be tested before they get discharged. The staff, again, about all PPE. Basically, it's providing full protection both to the staff and the patients. And as I said, there should be attention to details of infection control and risk management, both preoperatively and post-op. There are precautions for surgery during the pandemic should not be different between COVID positive and COVID negative patients. The hospital policy is essential to protect patients and staff. The surgery on COVID positive patients can be undertaken as long as adequate precautions are taken. I'm fully aware that this is already happening in Egypt, but I'm encouraging everyone else to do it. There is no harm in doing it if you are protected. If you're not protected, do not do it. Every single person in theater needs to be protected. And again, I'm emphasizing on this point. I'm not sure whether the healthcare assistants are getting this, but every single person should be getting it. One person catching the infection will spread the disease to everybody else in the hospital environment.
Thank you very much, Ismail, for an interesting presentation and very specific and to the point. We have a poll question.
Yes, please. Yeah.
We need the poll, Dr. Ahmed. We need the poll question number 6, please. Yes. Can you read the question, please, Ismail?
So when operating on a patient who is not known to be COVID positive, who should be wearing personal protective equipment?
Okay, I think we better end the poll now.
Yeah, this is a great response. Please, the person who answered that only the operating surgeon and the assistant and the anesthetist, but not the nurses, please do not do that. Every single person needs to be protected. Maybe it's a mistake. I'm hoping it's a mistake.
Excellent. Well, thank you very much, Ismail. Any questions, Professor Hazem?
Well, I'm actually impressed. This is a very compact system which allows the COVID patient to have the full right of being treated if he is in need for surgery, and at the same time, it's a good protection. I would say rather a good protection for the health providers. So for the healthcare providers. So thank you very much, Ismail, for this compact kind of advices. And I would say that in the present status in our in Egypt, it's not I wouldn't say allowed, but not welcomed at all to have a COVID patient in the regular hospital service. They are until now they are always isolated in isolation hospitals or in isolation centers. And I was wondering all the time if one of these people has got a kind of emergency, what kind of emergency treatment will be done for them. All what people are concentrating in is that how they can treat this patient or protect him from passing to further complications or so. And I think the guidelines given by you and Sherif Haqqi will be a good guidelines or advices or respected experience in doing this if ever these patients went into a kind of emergency. Thank you very much for this.
You're welcome. You're welcome.
Thank you, Professor Hazem. I think we should head on with question 7. Professor Mohammed Al-Mishtawi should ask question 7, please.
Thanks, Sam. Back again to Amjad. Please, can you shed light on which patients with symptoms you are instructed to do, or and when you are obliged to go to hospital to operate on Amjad?
Okay. Thank you, Professor. So the guidance in the UK for COVID positive patients has been very clear. So, is my screen shared?
Yes.
Oh, yes.
Okay. So first, patients are guided that if they have fever or a continuous cough, they should self-isolate and not go to hospital. The continuous or persistent cough was not clearly defined until recently, and most people are not even clear about this definition. So persistent cough is if you're coughing a lot for more than an hour, or if you have 3 or more coughing fits within 24 hours. As I said, in my case, we could not classify it as a persistent. So the NHS told all patients, if they have these symptoms, to stay at home to protect the NHS and save lives. And then this guidance changed to people to stay alert rather than staying at home, to control the virus and save lives. Again, it was a confusing message and not very clear to everyone. Staying at home, the advice was to stay at home for 7 days from the onset of symptoms. And anyone living with that person self-isolating should stay at home for 14 days. This, however, is not exactly in line with the evidence about the shedding of the virus, because the study from Wuhan have showed that on average, people shed the virus for 20 days after the infection, and in some cases was up to 37 days following the infection. I think this was not the best advice in the UK regarding coming back to work after 7 days, especially to people working in the medical field like myself, when I came back to be exposed to patients and to other colleagues. Based on the study from Wuhan and other evidence, the CDC has changed its guidance on going back to work, that employees should have received 2 negative tests in a row 24 hours apart. This is not applied in the UK yet. However, the only cases where we apply that they need to get a negative test before going back to their normal environment is patients in hospital coming from care homes. Because of the spread in care homes has been so high, so currently we do not send any patients back to the care home until they have 2 negative tests 24 hours apart. The advice to go to hospital in the UK because of COVID-19 and not because of any other injuries is limited to patients having severe pneumonia. So those having severe shortness of breath, coughing blood, having blue lips, feeling clammy and cold with pale mottled skin, collapsing or fainting, or becoming almost unconscious, and having very little urinary output. More recent advice for GPs and people working in the NHS is actually to self-isolate even if they test negative. So if they have positive symptoms, but the PCR test is negative because there's incidence of false negatives, then now they should self-isolate based on the symptoms despite the test. The advice now about reinfection. So if someone had already had COVID-19 and has the symptoms again, there is specific advice for them. If they were tested before and tested positive, then they should do nothing. They should just carry on going back to work despite their symptoms, which to me does not make much sense. And if they did not test before or tested negative, then they should self-isolate as if it's their first time. It seems to ignore the evidence and the advice from the WHO that there is currently no evidence that people who have recovered from COVID-19 and have antibodies are protected from a second infection. So the new symptoms can be due to a second infection. And in my own humble opinion, and going with the WHO guidance, that these people should be tested again and should self-isolate again if positive and not just ignore the symptoms. Unfortunately, to date, as Sharif had said, 312 people have died who work in the NHS and care workers in the UK. So what could have been done better in the UK? I think clearer messages from the government. The continuous or persistent cough has been misleading to many people. Early testing should have been available for everyone, and especially for medical staff. People shouldn't need to fight for 4 hours over the phone to get their test done. And PPE availability now is readily available, but was not available at the start, and we had time to build up. Lockdown should have been started earlier, and I think retesting is something we're still missing on, especially for medical staff. I think they should be retested before going back to work. And this is my current respirator mask that I've been tested on and the one that I've been using for all my surgeries now. Thank you and stay safe.
Thanks, Amgad, for this conclusive summary. Actually, I will take you to one aspect away from the medical field, if you allowed me to do that.
Sure.
All of us have enough gray hair to answer this question. Do you remember when the SARS for the first time hit the nations in 2004 and again in 2014? I am confounding that in every time before we hadn't seen these instructions and this huge dilemma about the coronavirus. Do you have any interpretation, logic interpretation for what we see now from this huge instructions and WHO move against coronavirus? Starting from Professor Hazem Abdelazim. Do you think, Professor Hazem, that it is a real pandemic, or what do you think about the background reasons for it?
Dr. Hazem, if you please unmute yourself.
مؤكد انها بانديميك. كل الناس اجمعوا على ان there is no even a single country which is not affected or which is not having any kind of precautions to protect their people against this risk. There is no doubt. And it's not comparable to any kind of epidemics which I have witnessed during my my life. We know from the history that some kind of viral attacks has happened, like the Spanish Spanish epidemic, which was considered as a kind of pandemic at that time also, but it's not by all means comparable to what we are in now. What we are in now is a kind of very aggressive kind of virus or microorganism, which is not understandable. We are only, what we are doing only is that we are trying to protect ourselves from getting infected by this virus. We don't have any kind of, I can't see any kind of hope at the moment in treatment, in active treatment, except that you build up your health so your immunity can support your health and pass without any kind of serious complications. I hope that we can go on with this, at least at the moment, especially in Egypt, where the direction now is towards restart of a kind of, I wouldn't say normal activities, but the essential activities of the people, because the complete lockdown.
Thank you very much.
The complete lockdown in Egypt is really a serious issue from the economic point of view, according to what I can say.
Thank you very much, Professor Hazem, Professor Mishtawi. There was a question from Dr. Hussam Gad. He was asking, what are the items of the questionnaire that you would ask your patients coming to your clinic to screen them for the possible COVID thing? I understood there were just a few questions that I think Sharif said at the beginning. Yeah. So they are. Could you just tell us again what are the questions you would ask patients?
The patient is arriving from a care home. This is a situation, I'm talking about the UK. Then this is automatically a high-risk patient.
Mm-hmm.
He cannot enter the green zone. This is number one. Number two, the temperature is taken. We used to ask them about the temperature, but now it's taken. And then you ask about the 3 symptoms of cough, persistent cough, or cough. Amgad never had persistent cough, but you just ask about cough in general. Loss of sensation of taste and smell, and GI symptoms, mainly diarrhea. These are the screening symptoms. You can make them as long as you need to. Sometimes they can cover many other things that are not covered here, such as backache and headache. But these are the 5 screening questions in our site.
Thank you, Sharif.
We do the same, and we actually still ask them about temperature in addition of taking the temperature, because some patients might have had paracetamol just before coming to hospital, and that will drop their temperature. So we just ask them about the history for that as well.
Excellent, Amgad. Now, Amgad, did you undergo a testing? Did you have a swab?
Yes, I did. Yeah. So I did it 4 hours after negotiations over the phone, and managed to get it done the day when the symptoms started.
And you went back to work after testing negative or without doing that?
No, without testing negative, and that's my criticism of the system.
Very interesting.
Yes. Is the swab as painful as they say?
محدش يعمل كده غير أمجد نخلة يعني.
أنا ما كنتش عاوز. They said I had to.
أمجد بيحب قراره لنفسه وبيحب المغامرة. مش أدفايس تتقال للناس يعني الحقيقة معلش أمجد يعني علشان.
I thought I should have tested negative before coming back to work, and I think that's a mistake in the system that they allow medical personnel to come back to work exposed to patients and colleagues without being retested and showing a negative result.
It's very interesting that they ask patients to stay in for 7 days, but while they ask the contacts to stay for 14 days, I think that's ridiculous.
The point of that is the symptoms can take a while to appear. So it can take a few days later. So for example, with my wife and children, they started having the symptoms 5 days after me, yes. Although we were separated in those 5 days. So they actually got infected by me before I got any symptom. And that's why they give it the period of 14 days, the first week, plus another extra week when they get the symptoms. But again, there is no evidence that patients become non-infectious after 7 days.
Fantastic. Thank you very much. Now we go to the final question. Professor Wael Qubtan would ask the final 8th question.
Sure, but obviously Amgad is so indispensable that they needed him after 7 days to go back to work. Well,
right.
Last but never least, our dear Dr. Fadi. Dear Fadi, I understand you are working with your hospital to restore elective services. Would you please tell us the points you agreed on with regards to suggested pre- and post-operative care?
Thank you very much, Professor Qubtan. Yes, I'm working with an advisory group in my trust to try to restore the elective services at my trust. It's not at all an easy job. It is very, very challenging with many aspects that I will share with you now. So first of all, let me just, for the sake of time, just divide it into several challenges, starting from the hospital to the staff to the patients and other logistical issues that we are going through at the moment. This is the guidance issued by the British Orthopedic Association, and I think it applies to all other specialties as well in terms of dividing the hospitals into gold, silver, and bronze. The gold being that it is a separate hospital where elective, which has only elective procedures done in. Obviously, there are very few centers in the UK which can be declared gold because it has only orthopedic patients or pediatric patients or cardiology and so on and so forth. Silver hospitals, where they are buildings that can be physically separated into distinct areas. And this is the work that is ongoing at the Royal London Hospital in order to try to create, as I'm going to describe now, a green area where the patients undergoing or are going for elective procedure can have a separate entrance, separate corridor, separate lift, going to a completely isolated ward and operating theatre suite. And obviously again the associated services like high dependency unit, radiology, and so on and so forth. It's a massive challenge to create this area within a blue and otherwise blue hospital. Blue means that areas with COVID, creating a green area, non-COVID area within a blue area is quite challenging process. And bronze are departments that you cannot physically segregate a green area from a blue area. At the patient level, obviously, here is the guidance issued by the Royal College of Surgeons, in which patients are divided into 5 categories in terms of the time. So if it is within 24 hours, then it is 1A, 72 hours, 1B, up to more than 4 months. Surgery can wait for more than 3 months. They are priority 4. And I encourage all my colleagues in the surgical field to think about determining this classification in terms of determining the priority. But also, as an example, priority level 1A would be traumatic spinal injuries, so spinal fractures that are unstable, cauda equina syndromes, acute spinal cord compression. And to the other extreme, priority level 4 would be the arthroplasty surgeries, degenerative spinal disorders. But also equally important is to think about the risk stratification, which my colleague Ismail has mentioned twice, and I should reiterate the risk stratification in the process. So you have to consider all the risk factors for the patient that makes the patient at a higher risk of COVID pneumonia or even mortality should he catch the infection. And after going through the risk, you have to risk stratify them into low risk, medium risk, high risk, and very high risk. So this is from the hospital point of view and from the patient's point of view in terms of risk stratification, priority stratification, but also the preoperative preparation. Number one, so far, the guidance issued in the UK and all the guidance coming from America as well, they suggest that patients should be instructed to self-isolate for 14 days within their household. And some guidance go the extra mile of asking the household to self-isolate with the patient as well, which obviously so many patients will find it very challenging, and we are expecting a big backlash from that one. And for that reason, they issued something about self-shielding within your residence. Should your household are not able to self-isolate, so you have to observe social distancing, you have to have your own area, and there is a specific guidance that I can share with whoever is interested to know. Screening for symptoms, again, the same questions should be asked to the patient a few days before coming to the hospital, prior to his elective procedure. Patient has a duty to call the hospital and inform the surgical team should he develop symptoms whilst self-isolating. Testing, we test for we do the PCR for COVID-19 prior to surgery, 48 to 72 hours prior to the surgery, and obviously the patient has to test negative. Again, the patient is instructed to observe social distancing prior to treatment, and even within his house, and also, for example, on his way to the testing facility, and it has to be a drive-through testing facility. On his way to the testing facility and back, there are detailed instructions, and also going to the hospital on the day of surgery. So it has to be watertight instructions. I'm not going to talk about theatre because Ismail already explained it nicely. Post-operative care, there are a few challenges, but the post-operative care should start pre-operatively. In that, again, if I anticipate any problems with the patient leaving hospital very early after the surgery, should anticipate it. For example, social care, which should be in place, waiting for the patient to come back, and so on and so forth. Daily ward rounds by a senior member of the team in order to make sure that the recovery process is going as expected, or even at a quicker rhythm, and also to solve any problems with the patient care. There has to be a clear communication with the community care and the primary care, and the advice is to start this communication quite early, so that the patient, when he goes back to the community, he would have all the support and care, and so that they would be expecting the patient quite early on, and not the standard inpatient stay as used to be before the pandemic. Now there are very, very less resources for physiotherapy, occupational therapy, so the patients are given the advice and instructions before they leave the hospital, and it has to be a self-directed physical therapy, unfortunately. Our team can provide some virtual consultations for physiotherapy and follow the patient up virtually. Patients can use, as Professor Hussam said, use this to their best interest, in that they can send pictures of the wounds, pictures of swellings, and so on and so forth to the surgical team, asking for advice. At the staff level, obviously, this situation is still very dynamic, very fluid, but what we have so far agreed on is that the staff will have to be regularly tested 2 to 3 days prior to the elective operating theatre list, in order to do everything, and we have to keep the green area green, and we do not blemish it. Psychological support to different team members is quite important. Obviously, because of the procedure of intubation, positioning, donning and doffing the PPE, the time in between the patients in order to leave a chance for the theater to be cleaned. So we have to be sure that we include less number of cases on the operating list. The issue, the guidance issued by the BOA, the British Orthopedic Association, is that we should be seriously considering 2 consultant operating because of the prolonged time of lockdown, in order to face any issues with de-skilling, but also to speed up the procedure in a safe manner. At the service level, obviously, there is a lot to be said, but because of time restrictions about consenting and the changes in the consenting procedures and what we should add to our consenting procedure, preoperative assessment, the staff rotas, because obviously now we are talking about having a separate hospital within the hospital with their staff who are not allowed to go into the blue area and, for example, share in other orthopedic procedures for fixing fractured bones and so on and so forth. Allied health services, again, we don't have the resources to offer 2 teams of occupational therapy, physiotherapy, and so on and so forth on the blue side and on the green side. So this is another challenge that needs to be resolved. Radiology, because up until now in my hospital, we still have patients isolated for COVID, patients in ITU who would go to X-ray, to go to CT, go have their scans done. How are we going to manage this with the with having elective patients who would require X-rays? We're still in a debate, and that's it. Poll question, Professor Hussain, please.
Yes, please. Yes, thank you very much, Fadi. Dr. Ahmed, poll question number 8.
So what instructions does the surgeon give to the patient pre-op? And I don't mean to copy from my talk. I mean, what do you think is reasonable from this list? Should we be telling patients to isolate 14 days, have a test 2 to 3 days, include the risk of COVID in the consent, inform the hospital if the patient develops pre-op symptoms?
What about the surgeon? Would the surgeon isolate himself for 14 days before doing an operative list?
Actually, that's a great question, Dr. Hussain, and I'm not kidding here because there are multiple ongoing meetings as we speak every day in all different communities and subspecialties, like the knee surgeon, the spine surgeon, the upper limb surgeons, and there are some voices out there that say that the surgeon should equally be self-isolating, but so far there is no official guidance with that, and I hope they don't do that because I think it's a terrible overkill, and that if the surgeon is asymptomatic, has not been in contact with any COVID positive patient, and tested negative 2 to 3 days before his elective list, so far it is more or less agreed on that this should be sufficient.
Okay, excellent. Professor Hazem Abdelazim, Professor Wael Obtan, do you have any questions ready?
Yes, please. Fadi, what's your approach if a COVID negative patient develops, let's say, low-grade fever on his first or second day post-op? What would you recommend that we do?
So thank you very much, Professor Obtan. Again, another great question. I think in my point of view, or again, I didn't, there might be some guidance out there on that, but I would straight away treat him as a suspected COVID, and that patient should move out to from the green area, should be tested straight away, and thankfully now the results are available quicker. There is a quick kit available within 1 to 2 days, but it should be removed from the green area. Again, all the staff in contact or patients that has been sharing the bay, again, should be tested.
Now the problem with this is exactly what we're doing. But unfortunately, there is a problem with what we are doing, which is not making sense. Now we've got a patient who developed fever post-operatively, which might be secondary to anything, even post-operative atelectasis, anything. And then you send this patient to a ward with other patients who are suspected positive, and they're all sitting in the bay, in a bay of 6 patients, 6 or 8 patients. And now this patient is prone to catch COVID-19 infection from another suspected patient who's ended up being positive. So basically, we don't have an answer. And this tells you how we don't have an answer for everything. Nobody has got the answer.
I don't know. Yes, you are absolutely right. We don't have all the answers, but I'm not sure. I mean, in the trust that I work in, the suspected patients are isolated in a side room.
We don't have this.
In ours as well, it's side room. But another thing as well that we...
You're muted, Amgad.
So I said, yeah, in ours as well, it's we put them in a side room. But another thing we've been working on, in particular with patients who develop a fever or a cough after surgery, is to try to get them home as soon as possible. So we don't have to wait until they fulfill all the criteria that physiotherapists have want them to fulfill, but to get them home as safe, as quick as possible, to isolate in their own homes rather than isolate in the hospital, and if they were not infected, get a positive infection.
Yeah.
Can I just interrupt you guys here and tell you what is the current practice in the hospital that I work in?
Please.
The current practice is to have patients have a CT chest on admission and some routine labs. And if these are all negative, we operate on these patients as if we are in 2019, not in COVID-19. And we use regular surgical masks. We use just a single gown and double gloving as usual. And we use a lot of praying. That's what we are very good at. So,
lucky us.
I mean, this is quite shocking, you know. I mean, what you guys are saying to me, I mean, I've been preparing this with you guys, but to me, this is actually quite shocking. Yeah,
to be honest, with the figures you have, they are much lower than what we have. So, yes, it's better to follow our... Sorry?
I'll tell you a very interesting story.
Yeah.
I sent a patient to I had a patient that I saw like 4 weeks ago. She had a previous surgery with another surgeon, and she had a huge meningitis, pseudomeningitis, a dural tear that got like a balloon out of her back. And at the time, she had very severe pain, and I said, well, you better go back to your surgeon and have it repaired. You need to do a surgery to repair the dural tear. They said, no, I want you to do the surgery. And then they disappeared. 3 weeks later, they called me on the phone. They say they're ready to have the surgery, and they were actually very keen on having the surgery immediately. We have to do the surgery tomorrow. She's in horrible pain. I'll send her to the hospital now. And I said, okay, send her the patient today and I'll do the surgery for her. بصراحة بس كنت مستغرب شوية يعني why is she in such an urgent situation? The patient goes to the hospital, gets screened at the entrance, and they find a temperature of 38.5. I haven't seen the patient. Neither of any of my team saw the patient. She was at the admission office and then taken to the ER at the hospital. Then they do a CT chest and they found ground glass, and at the time of ground glass appears the periphery of the lung. And while she was being interrogated by the A&E department, they asked her a few questions. She had respiratory symptoms and she was actually in kind of respiratory distress. She had some ground glass on the CT and she had a quite excessive pleural effusion, which is not common with COVID-19. Anyway, she was transferred to a hospital of isolation hospital, to another hospital. And then through the phone, I found out that she turned out to be COVID positive. So it's actually, and I was actually very much against the idea of doing CT to all patients who are asymptomatic. I haven't seen an asymptomatic patient with CT changes yet. I also wonder about the radiation dose and who's responsible for the risks of the CT despite being small, but there are risks of getting exposed to CT because of radiation. And then you find, I've been told by chest physicians that some patients will be completely asymptomatic and have even CT changes of COVID.
Can I just explain a point here, because that's a very important point, Dr. Hussein. Because if we have a patient who is symptomatic, so suspected of having COVID and tested negative, then we do a low-dose CT scan. So this is the indication to do a CT in the UK now, is that he's coughing, he's tested negative.
لا أنا بتكلم على مثلا you send a patient for discectomy, a 37-year-old for lumbar discectomy. The patient has absolutely no symptoms, no chest symptoms or any of that, no temperature, CBC, ESR, CRP are normal, all that. They will still do a CT chest for him instead of doing a PCR. Instead of doing an antibody test.
هي حاجة بيعملوها في مستشفيات كتير هنا، لأن هم مش عاوزين أساساً يدخلوا patient إلا لما يكونوا قالوا إن إحنا we could screen this patient somehow وما لقيناش عنده possibility إن هو يبقى كوفيد. واضح من الكلام اللي سمعناه من الاكسبيرينس بتاع الدكاتره فادي واسماعيل وشريف وامجد انه الامر مش متاخد كده. بالعكس الامر في حاجه تانية، وهي انه البيشنت ده من حقه ان هو يعمل السيرجري اللي احنا عايزينها لو كان في ايمرجنسي. فاحنا دلوقتي احنا اللي هناخد بالنا من نفسنا، لكن هو هيعمل العمليه. وحكايه انه يدخل في المستشفى ما يزالوا في مصر، ما نزال هنا سيجريجيتنج اللي عنده من اللي ما عندوش، بس مش اللي عنده، لا اللي مشكوك فيه من اللي عنده من اللي ما عندوش. اللي احنا بنتعامل معاه حسام في الجراحه غالبا هم اللي ما عندهمش، او اللي المفروض ان هم ما عندهمش according to الثلاث حاجات اللي بيعملوهم عاده، وهو السي تي سكان، وده هم معتبرين ده ماستر بيس، ومش له دوز ولا حاجه، ده سي تي سكان جينوين يعني
فول دوز،
مش زي ما فادي بيقول لو دوز وبتاع عشان انت قلت له الاكسبوجر والكلام ده. لا انا عارف ان هم بيعملوا جينوين سي تي سكان. والحاجه الثانيه اللي هي احيانا بيعملوا طبعا بلاد بيكتشر وبيشوفوا ما اعرفش الليكوسيتيك كاونت وبيقولوا بعد، وبرضه بيعملوا البي سي ار. لكن هل ده كونكلوسيف ولا لا؟ The answer is طبعا لا. To some extent it is convincing. لما بيلاقوا patient عنده manifestations بيقولوا له ارجع البيت، اقعد تحت التريتمنت الكذا كذا كذا، و لما بيلاقوا واحد بقى فيه البروبلم طبعا بيودوه المستشفى فالعزل. فانا حاسس يعني زي ما امجد بيقول ان الاحصائيات هنا هنا اقل الحمد لله في مصر كتير، لان برضو الطريقه دي مش مخليه البيشنت اللي عنده مانيفستيشنز يختلط بسهوله مع بيشنتس ثانيه في المستشفيات، لكن هو بيختلط في المجتمع. هي دي المشكله.
انا بس انا عايز اقول نقطه واحده في الموضوع ده. لو انا هقول نقطه اخرانيه يعني، هو ان احنا لازم احنا كدكاتره نبقى واخدين كل حذرنا ان احنا نحاول واحد نبقى سيف عشان نفسنا، لان حوالي 18% من العيانين دكاتره لو هنبص على الموضوع جلوبالي يعني. والحاجه الثانيه ان احنا بالتالي بنحمي عياننا، وعلى الاقل نبقى تيكينج ذا بوكس يا بيه بتاع ان احنا وي ار فولوينج سم سورت اوف بروتوكول، عشان لو حد اتعدى ما يبقاش احنا الايسيمتوماتيك كاريرز اور سو اون. دي حاجه مهمه جدا، لان احنا عندنا في مصر حضرتك عارف ان الرعايه الصحيه اغلبها رعايه صحيه خاصه. طبعا المستشفيات الجامعيه ومستشفيات التامين الصحي بتلعب دور كبير، بس
مش اغلبها يا شريف، مش اغلبها
لا
هي اغلبها ناشونال سيرفيس فعلا، يعني اغلبها ناشونال سيرفيس، بس الناشونال سيرفيس مش نموذجيه،
مش بالظبط. يمكن ده اللي انا قصدي اقوله. فانا
اغلب الناس بياخدوا الخدمه لما هتشتغل، لو اشتغلت في العمل العام في الاداري وكلام من ده في مصر، هتعرف ان كميه العلاج اللي بيتعمل على الببليك سايد او على اللي هم الناشونال هيلث كبيره جدا عن لكن السكسس ريت في البرايفت اكتر.
لا طبعا انا مش عارف الارقام الحقيقيه، بس اللي انا عايز اقوله لحضرتك يا بيه حاجه هنا عن الاسم بتاعي انا بس، واحنا جراحين جنرال سيرجنز، وقلما بيبقى عندنا الميجر تروماز اللي انتوا بتشوفوها كل النهار، انتوا تروماز البريد اند باتر بتاعكم، احنا اقل كتير. احنا الاسم الجراحه بتاعي فيه 18 جراح على 3 مستشفيات، منهم ناس ما بتروحش من مستشفى لمستشفى، وامجد عارف المستشفيات دي كويس جدا لان امجد كان جزء من المستشفى دي قبل ما يروح مستشفى الجامعيه الثانيه بتاعته. ال 18 جراح دول 17 واحد فيهم عيه ببوزيتيف PCR وكلهم جالهم كوفيد بوزيتيف. وانا ال 18 وانا ما عيتش، لان انا عييت غالبا في يناير قبل ما نعرف اي حاجه خالص عن الكوفيد ده، وقعدت في السرير ما كنتش عارف يا بيه اقوم اخش الحمام، وما بقتش فاهم ايه اللي بيحصل من وجع ظهري. فوات ام تراينج تو سي ايه، الناس دول عيوا في مارس في اوائل مارس، كلهم عيوا في وقت واحد لدرجه ان احنا اسم الجراحه بتاعنا ابتدينا نستلف جراحين من ناس ثانيه. انا بقول لحضرتك النقطه دي ليه؟ لان لو احنا كنا واخدين الامور بمنتهى البساطه في الاول زي ما امجد حكى قصته، كلنا كنا عاملين كده وكمل لستيتو ان سو اون، كل الناس كانت عامله كده، اللي بيكح واللي عيطس انا ما عنديش وانا ما عنديش. احنا لازم نبقى اتعلمنا من اللي شفناه في انجلترا وايطاليا، انا بتكلم نفسي دلوقتي عن احنا كمصر، ونبتدي نبقى مخليين بالنا زياده عن اللزوم قوي عشان احنا ما نتعديش وما نعديش، فبالتالي السيرفيس تو ستارت تو بيك اب وذا ريل تيست زي ما فادي قال is when the elective work starts. احنا النهارده مستشفياتنا الجامعيه فاضيه، بنهزر ما بنعملش حاجه. عايز اقول لحضرتك احنا يعني حاليا مجموعه عواطليه اوكي الا تروما. يوم لما نبتدي ندخل الاعداد اللي احنا بندخلها ونبتدي المستشفيات تملى، this is the real test. ولو حصل في يوم من الايام زي ما حصل في ووهان البيبر اللي فادي اثرها واسماعيل اتكلم عليها، 34 عيان، ال 34 عيان نسبه الكوفيد 100%، يعني حاجه مش هتحصل تاني، فاحنا لازم نتعلم منهم نشوفها معاهم ايه. 100% كوفيد بوزيتيف دي مصيبه، فاحنا لازم نخلي بالنا عشان ما ننقلوش لمرضانا، عشان الشغل يبيك اب تاني في العمل العام والخاص وبس ان شاء الله يعني.
عاوز اقول لك حاجه يا حسام.
نعم يا بيه.
على الموضوع بتاع البيشنت اللي بيظهر لك فجاه برايفتلي ويقول لك انا كنت شفتك من شهرين، تعال اعمل لي العمليه بكره. انا شخصيا هتكلم عن نفسي، انا حصلت معايا 500 مره. الواحد بيفرح جدا طبعا. تجيب الفايل بتاع البيشنت تطلعه بسرعه وتبص فيه تلقاه مثلا كان هيعمل ارثروسكوبي اوف ني مثلا، يعني تقول له اوكي اجي اروح بكره. طبعا تروح بكره، لسه بكره فاضيه يعني وعايزينها تتملي. يدخل يعمل عمليه، وبعد العمليه بيوم يجي له بالمونري امبوليزم، يطلع ان الوجع اللي جاله وجابه عندك ما كانش البين بتاع الركبه بتاع كان انه جاله دي في تي لانه حاول يقعد عشان يعمل الحكايه دي. افظع حاجه قابلتني في هذا الموضوع، واحد من اصحابي انا من زمان، او يعني بالاحرى اخوه كان صاحبي قوي، كنت بشوفه كتير لكن هو كنت بشوفه قليل. هو بيزنس مان وويل نون في المجتمع، وجالي ركبته بتوجعه وعنده ديفينتلي باكت هاندل تير في المنسكس، بقاله هو مده مش قادر يقدرها، لكنه لما يحصل له لوكينج بيجي لي وعارف يعرف انا فين، او بيروح 2 دكاتره تانيين اصحابنا في مصر الجديده بيروح لهم، ومرتين اتعمل له ان لوكينج. مره جه وقال لي بقى خلاص مش ممكن، بس جه العياده ماشي يا حسام، مش جه كده. وبعدين انا شفته وكلام كنا بنتكلم جد جدا، قال لي انا خلاص عايز اعملها، انا مش قادر. اوكي اتفضل، تحب تروح امتى؟ قال لي اروح دلوقتي، انا رجلي وجعاني جدا. قلت ايه ابن المجنونه ده يروح دلوقتي يعمل ايه؟ احنا كنا بالليل بنشتغل عيادات، او يعني الساعه 5 يعني، وراح بالليل فعلا. الصبح لحسن الحظ انا رحت اشوفه في الاوضه، وده ما بنعملوش عاده مع الاسف الشديد برضه، دايما كروتين ببقى شايف البيشنت قبلها بيوم، هدخل اكشف عليه تاني ليه؟ لكن دخلت ولفت نظري ان هو بيشتكي من ساي بين المره دي، فقلت ده هيعمل زي بتاع الدي في تي. بفحصه ما قدرتش اكونكلود اي حاجه، عملت له اكس راي لقيته عنده فراكشر نيك فيمر. كويس؟ فراكشر نيك فيمر عادي خالص، الصوره عاديه جدا بتتكلم عن نفسها. قلت له انت وقعت؟ قال لي لا. انت اتعورت؟ قال لي لا. انت عملت ايه؟ قال لي انا جات لي لوكينج من كام يوم ورحت عملت ان لوكينج وبعدين دي وجعتني. ات سيمز ان هو اتقرص عليه في روتيشن ولا في حاجه. المهم انه انا بتخيل بقى ان انا كنت خدت الراجل ده ودخلته عشان اعمل له ارثروسكوبي. انا مش ارثروسكوبيست فتك قوي، ف ولقيته بعد العمليه جاله فراكشر النيك فيمر بعد الارثروسكوبي يعني. فهقول ان هو فعلا انا اللي كسرته.
اكيد.
خلي بالك من المفاجآت دي لانها مش حلوه. مش حلوه، ودي طبعا غالبا مش هتحصل الا في اون ذا برايفت سايد. اللي بقى له مده ما جالكش وظهر فجاه ده جاي بحاجه ثانيه بنسبه كويسه يعني. سوري ان انا حكيت لكم حكايات بره، بس انا ايمنت ذات لان احنا في الاخر دلوقتي. وانا سعيد ان انا قابلتكم يا جماعه والله اونلاين. وكل واحد فيكم عارف انا يعني قد ايه سعيد اني شفتك يا مشتاوي جدا يعني.
الله يكرمك. الله يخليك.
ان انا اقابلكم في اسيوط السنه دي زي كل سنه.
الله يشرفنا.
والحقيقه يعني اسيب الدكتور حسام يقول كلوزنج ريماركس، واتمنى اشوفكم ان شاء الله في مصر قريب ايها الانجليز، واتمنى اشوفكم.
ربنا يخليك يا بيه.
ربنا يخليك.
انا اتمنى نشوف حضرتك ان شاء الله.
عايزين نشوفك تاني. في ناس تخان كتير يا شريف مستنيينك يعني.
والله يا بيه انا كمان مستنيهم يجوا، بس ده مهم جدا عايزينهم دلوقتي يعني. اقول لحضرتك يعني
شوفوا مره ثانيه
يعني عمرهم ما وحشوني قد ما وحشوني دلوقتي يعني.
مبسوط اسماعيل. تحياتي القلبيه اليك يا ابني يا اسماعيل يا حبيبي.
الله يخليك يا بيه، وحشني والله جدا.
ان شاء الله نشوفك بكل خير. تحياتي.
Just to say my story with COVID-19 in our Egyptian community. And here in our Egyptian community, if we have time, Hassan, please, I can
طبعا قول يا مشتاوي طبعا. قول احنا كلنا بالعربي دلوقتي، مش محتاج تكلمنا بالانجليزي، كلنا موجودين بالعربي دلوقتي.
في شهر 11 تقريبا احنا دعينا الإيسا ان احنا نروح الدمام الثيرد سعودي سباين سوسايتي. فكنت انا والدكتور علي وبعض الاخوه هناك. بعد ما رجعنا في اواخر شهر 11 طبعا رحنا عملنا عمره وكده ورجعنا. بعدها باسبوع لاحظت ان انا خدت انفلونزا شديده جدا زي ما الشيف بيقول كده. انا ما كنتش قادر اتحرك من مكاني، كانت حرارتي عاليه جدا وصلت في بعض المراحل ل 40 درجه، وكان عندي هالوسينيشنز وكده، واستمرت الاعراض لفتره طويله. انا ساعتها قلت لزملائي ان دي لا يمكن تكون كومن كولد او انفلونزا عاديه، دي لازم تكون حاجه ثانيه. بعدها طبعا بدات عند شهر ابريل بدات الدوشه بتاعت الكورونا فيروس دي. فبدأ الناس تخاف وتترعش عندي العمال والدكاترة وكده، إن يا بيه إحنا هنبقى معرضين وكده. وحاجة مهمة جدا طبعا إن أنا عملت انستراكشنز زي ما حضراتكم كلكم قلتوا، بس في نقطة مهمة أنا عملتها لنفسي، رابيد تيست. الرابيد تيست I think there is some political reasons اللي مخليه rapid test is not available. It is يعني بصراحة يفرق جدا 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 في البراكتس إنك to have rapid test. I did rapid test for myself and it was positive for IgG. That means I have a solid immunity against coronavirus. I know there is a percentage to reinfected again, but at least immunity. That means when you are infected again, you would have benign symptoms, not so severe like non-immune. Why not? Rapid test is done for every patient entering the hospital or for every doctor treating COVID-19 patients. And do you know, we are Egyptians, مصريين دايما عندهم في الفرونتال لوب حته كده بتاعه الكونسبيرسي ثيوري، بتطلع لوحدها كده يعني ما لهاش علاقه بالمواضيع.
انا هقول لحضرتك على حاجه. احنا في القصه دي من البدايه خالص، وانا كنت مره حصل تشات كده ما بيني وما بين الدكتور حسام على موضوع الانتي بودي تيستنج. كانت مصر بتحلل الانتي بودي تيستنج في المطار، وكان في كلام على ان في انتي بودي تيستنج على الناس اللي بتعملها. الانتي بودي تيستنج دول في كذا نوع موجودين. لسه الاسبوع اللي فات شركه روش مطلعه الانتي بودي تيستنج اللي هو has been considered as a reliable test with high sensitivity and high specificity. الكلمه اللي بتتقال دايما، احنا هنا في كل يوم المؤتمر بتاع الحكومه بيطلعوا كل يوم يتكلموا الساعه 5 الظهر، وانا بتصادف ان انا بكون ماشي من المستشفى، فانا بفتح الراديو وبسمع، ودايما بيكون في واحد جاي من NHS انجلاند بيتكلم. الراجل ده من احد الحاجات اللي كانت بتتقال، وانا مش واخد كلامهم مصدق في كل شيء، انما في كلام معين when they say it makes sense. بيقول لحضرتك ايه؟ بيقول an test which is not sensitive enough is as good as a bad test, as no test. يعني a bad test is as good as no test. لو طلع لك تيست ما هواش فيه sensitivity عاليه وما فيهوش specificity عاليه، يبقى مالوش قيمه. التست الجديد اللي طالع من روش هو ده الوحيد اللي واخد ابروفل دلوقتي، وده للاسف الشديد ده مش هيبقى وايدلي افيلبل لسه. فكل التست الثانيه اللي موجوده ما حدش يقدر يقول عليها ان هي انا طلعت بوزيتيف، يبقى ممكن انا مش عارف بالظبط السبيسيفيستي بتاعته قد ايه، انما يو كانوت رول اوت بي الناس اللي هم ما هماش بوزيتيف. هي دي النقطه.
very important point. انا اعتقد يعني نجمع الكلام ده كله على بعضيه. اسماعيل هو اللي عنده الفاينل كونكلودنج ريماركس اللي المفروض يقولها لنا.
انا هشير سكرين معاكم. انا الفاينل كونكلودنج ريماركس هي كولكشن للي احنا كنا بنقوله، يعني مش كله، لان في حاجات الاكسبيرينس بتاعت امجد throughout الالنس. احنا it's a very few points, it's only 4 slides. Surgery during the pandemic is still possible, and always remember ان these are what we call هنا uncharted territories. احنا we are learning. انما زي ما شريف كان قال مصر عندها ميزه، وانا احنا ما حدش فينا يعرف هل مصر عدت ولا مصر لسه داخله على كيرف عالي، انما مصر عندها ميزه ان هي شافت بلاد ثانيه سابقاها. ف this is an ongoing learning process حتى بالنسبه لنا احنا. And there is a growing body of evidence. So every single day there will be lots of evidence. بس always keep up to date. وفي نفس الوقت look at proper evidence. في زي ما في ناس قالت في بيبرز النهارده بتتنشر ب 10 15 عيان ببير ريفيو زي الزفت، كانت حاجات عمرها في حياتها ما هتتنشر اصلا. انا I would highly recommend اللي انا كنت قلت عليها اللي هي بتاعت الكوفيد سيرج. Please have a look at it و please see the results اللي هم طالعين بيها واللي هم they will always continue updating. واتكلمنا على collaboration اللي هو مهم جدا ما بين الهيلث كير وركرز والبروفايدرز والميديا and the government. ده كلام محتاج ناس very influential. انا بتكلم مع ناس زمايلي في مصر شغالين النهارده بيتكلموا على ان في عيانين منهم اخويا، مش زمايلي، اخويا نفسه اللي هو نيوروسيرجن بيقول لي ان في ناس عيانين بمننجيومز وعيانين بكودا ايكواينا، العيان نفسه خايف ان هو يجي المستشفى. This is a role that the media should stop pressing patients ان هم ما يجوش المستشفى، او ان هم يعني احنا عندنا هنا ال NHS has been calling for patients to come. They have been making them feel more at ease about coming. They have to come. واحنا عندنا هنا نفس المشكله برضو، احنا مش ما عندناش. الاوت بيشنت زي ما فادي قال try to minimize الهوسبيتال consultation, utilize الفيرتشوال او phone consultations. وكان في حد بيقول ان ما فيش الفيرتشوال بلاتفورمز. انا I'm aware of كذا فيرتشوال بلاتفورم طالع وaware بكذا حاجه كمان طالعه. These would make things a lot easier للجراح وللعيان. وهيبقى في حاجات برضو تانية ميزه بالنسبه للناس في مصر، مش بتكلم بس على في كولكشن انما saving بتاع الدوكيومنتيشن. If necessary, make sure that patients are screened prior to attendance and they should attend on their own without the families. Adequate PPE is essential في العيادة. It's very easy. A mask, keep your social distance. And as we said, patients دايما should be encouraged to present with life and limb-threatening injuries. Emergency surgery will always have to continue. This is something that we can never stop, and this is why it's important in احنا risk stratify the patients and inform the patients undergoing major surgery in that there is a high risk of mortality, but on the other hand, there is a high risk of mortality if left untreated. And as we said, the full PPE for everyone in theater, مش بس الجراح ودكتور التخدير. وكلمنا على there should be no flow in or out of theater during surgery. And no difference in precautions for proven positive patients compared to negative patients. لو احنا هنعمل aerosol generating procedure, you can never rule out. وزي ما شريف قال 17 من 18 جراح عندهم في الديبارتمنت. انا عندي 4 جراحين عظم went off sick. عندي 3 جراحين عظم في لندن اعرفهم، منهم واحد النهارده بقاله 3 اشهر he's not fully recovered, he's still short of breath. كل ده حصل في البيريد الاولانيه. الالكتيف فادي كان اتكلم عليها resumption of surgical activity will eventually take place, but it's very challenging عندنا، و I suppose ان هتبقى برضه نفس القصه في مصر. المجموعه اللي كنت قلت لكم عليها اللي هي بتاع الكوفيد سيرج عملوا study لطيفه جدا، الارقام اللي فيها مرعبه. Anticipated number of cancelled elective surgery after 12 weeks of restriction is in excess of 28 million surgeries worldwide. عندنا 28 مليون عملية elective worldwide هيبقوا متأجلين. Hospitals should start thinking of segregated green areas for elective procedure, considering self-isolation 14 days prior to admission. ده حاجات جاية من عند الجايدنس اللي عندنا. Frequent testing of staff will be mandatory. وكلمنا برضو على risk stratification of patients. Remember, in COVID-19 infection and surgery can carry a high risk of mortality in patients undergoing surgery, especially high-risk patients. بس لو في حد من شريف وأمجد وفادي عايز يضيف حاجة, please do. وبس thank you again for having us. ويا ريت إن احنا نكون قدرنا نقول لكم حاجة الناس في مصر تقدر تستفيد منها أو تاخد منها حاجة for their own experience.
Thank you, Ismail, very much. Concise and to the point. You summarized what we really heard through the last, believe it or not, we've been online for almost 3 hours. أبطال يعني مسافات طويلة، سباحة المسافات الطويلة. Thank you so much once again, Professor Hazm Abdelazim, for giving us the honor of chairing this event and always giving us the wisdom and the knowledge of looking at things in different ways, in different aspects. Thank you. So proud of you guys. انتوا عارفين انتوا صحابي بس كمان انتوا you make me very proud. أنا لسه شباب بحاول أو at least بحاول أعمل كده، بس honestly انتوا you give me so much energy. I enjoy your company. انتوا عارفين ده كويس. بس هنتكلم في الحاجات دي ان شاء الله بعد رمضان. Thank you so much, Professor Mishtawi, Professor Upton. Professor Ali had to leave us because of an emergency. I hope he comes back home with some money or حاجة to help with العيد والحاجات دي. But again, thank you very much for this wonderful event. I've been text from friends, and Professor Muhammad Wafa بعت لي دلوقتي بيقول لي what a super session. This was very informative. The speakers were very well prepared. فيعني حاجات التعليقات كلها عظيمة. Thank you very much. We have to adjourn, and God bless you all. وكل سنة وانتم طيبين ورمضان كريم.
Thank you all very much.
Thank you very much. Thank you very much. Great to have it. Thank you very much.
Great.
Thank you guys.
كلكم تعملوا سكرين شوت للصورة اللي موجودة دلوقتي قبل ما
اعمل سكرين شوت وابعتها لي عشان ما بعرفش اعمل سكرين شوت.
بليز وانا كمان.
بترفع روحي المعنوية.
يا حسن.
لا خليها معاك.
20 مليون عملية يا بيه، يعني إن شاء الله.
أنا ما رضيتش أتكلم يا مشتاوي، بس أنت بقى تخليني أفتح على فكرة مشتاوي مصنع مستشفى سنتر ده حاجه ضخمه جدا، انا مش بهزر. هو يعني بالك العمال وبتاع، احنا عندنا استمارجي، هو بيتكلم عن عمال وموظفين ماس برودكشن. من 3 سنين بيقول لي حسام هو انت لسه بتشوف العيانين؟ قلت له يعني ايه السؤال ده؟ فقال لي افتكرت مثلا الفولو اب او مثلا تاني من العمليه، فبقول له يعني ايه السؤال؟ ما يعني انت لسه بتشوف العيانين؟ قال لي يعني انت لسه بتشوف العيانين؟ جاوب انت يا مشتاوي بقى. راجل مفتري صعيدي بجد. فقال لي بتشوف العيان في اوضه العمليات، في ناس بقى في العيادات وحاجات بتشوف العيان في اوضه العمليات.
اهم
براكتس تاني خالص، نجم يعني.
اهم بوينت طلعت بيها النهارده طبعا غير وجود الدكتور حازم عبد العظيم استاذنا العظيم جدا، واخواتي الاعزاء وائل قبطان وحسام وباقي الايماجرانتس دول اللي بيرفعوا رايتنا بره في انجلترا، احييهم جدا. بس اهم بوينت انا خدتها من اسماعيل النهارده 28 مليون اللي
38
اخبار كويسه جدا.
يعني لما
38 مليون
كلهم في انتظارك يا دكتور مشتاوي.
يعني ده شيء كويس يعوضنا عن الخساره اللي خسرناها في
عندي خاطر كده. انا اولاد خايف عليكم جدا صدقوني والله العظيم، انتوا الاربعه. مش عارف الحكايه ديت يعني الكلام اللي انتوا قلتوه ده خوفني جدا حقيقه يعني. فخلي بالكم من نفسكم يعني، خلي بالكم من نفسكم.
ربنا يخليك.
انا ملاحظ ان يعني
احنا عندنا نظريه، عندي نظريه ان اللي كان هيعي عيه.
بالظبط.
والله اسماعيل خلي بالكم من نفسكم، لانه حكايه الاي جي جي دي برضو بينت ان في ناس، ما هو امجد قال لك في حالات انفكتد، وهو مش اول واحد يقول كده، في ناس عندها. وخلي بالكم اننا بنتكلم كلنا كده عن اكسبيرينس بالترايل اند ايرور، واللي بيعمل كذا بيطلع كذا وبتاع. وده برضو على فكره مش كفايه يعني. انا مبسوط ان الاتجاه كله في اللي سمعناه ان احنا ازاي نحمي نفسنا واحنا بنخدم الناس.
بالظبط كده.
خلوها مني انا، لان انا اب كده وبخاف عليكم جدا يعني.
ربنا يحفظك، وفعلا ان احنا خليك بالنا على نفسنا ونفوق.
انتوا الاول، انت الاول،
وبالذات حضرتك برضه يا بيه خلي بالك من نفسك.
خلي بالك زياده عن اللزوم يعني امجد، عشان انت يعني برضو يعني طبعا كلنا بنضحي عشان العينين بتوعنا وعشان شغلنا وبناخد بالنا كويس، بس كلكم ارجوكم والله يا اولادي خلي بالكم كويس جدا من نفسكم.
طب يا بيه
انت اولا وبعدين بعد كده بقى الشغل والكلام
ده. حضرتك خلي بالك من
حاجه انك انت بروتكت يور سيلف كويس يعني.
لا بما ان حضرتك ذكرت ده، يا ريت انتوا كمان يا بيه والله تخلوا بالكم من نفسكم، لان الايحاء اللي عندنا من مصر احنا مش ما نعرفش. بس دكتور حسام بيقول ان الموضوع متاخد تو سام اكستنت، لا او مش تو سام اكستنت، هو مش متاخد سيريسلي يعني.
الخطوره في مصر مش في شغلنا في المستشفيات، انا صدقت هذا.
صح يا بيه،
المستشفيات
لكن هو بره في الشارع اكتر.
المشكله في الشارع،
في العيادات يا بيه.
العيادات انت في ايدك يعني. انا طبعا بطلت، انا مش عارف الوقت فات واحنا بنسرق الوقت من الناس ولا بنعمل ايه، لكن حديث يعني عايز اقول لك العيادات احنا في ايدينا حاجات كتير بنقدر يعني. انا بطلت شغل شهر مثلا، وبعدين لقيتني كل حاجه بالنسبه لي زهقت، وكل حاجه بالنسبه لي ومش عارف النهايه امتى. وطبعا انتوا تعرفوا ولادي اللي هم زي اخواتكم يعني من عمركم كلكم ودفعه ناس كتير منكم كده، هم اللي ضغطوا عليا عشان اقعد ابطل شغل شهر. لما بطلت لما رجعت تاني اشتغل عملت حاجات كتير عشان اقدر يعني ابقى مطمن شويه. انما مش مطمن فين؟ اللي بيركبوا المواصلات بقى والكلام اللي انتوا بتسمعوه دوت، ده اللي الحقيقه صعب. ف انتوا عندكم يا عيني جوه وبره، فتيك كير ان شاء الله، ان شاء الله باذن الله ربنا يكرمكم.
Thank you very much everyone.
ربنا يستر.
Thank you very much. And I will have to end this session. Before we end again, we have to thank Elixir Pharma, our sponsor, والشركة الراعية لينا for just giving us this facility and being with us with the technical support needed. Thank you Elixir. Thank you دكتور أحمد. God bless you all. Stay safe يا جماعة.